All right, let's get started. Good morning, guys. My name is Jeff Jenkins, Executive Director with the Texas Chiropractic Association, and I want to welcome you to our two-part webinar, Medicare for Chiropractors, Understanding Medicare. This is, again, a two-part session. This is part one today. Part two will be a week from today, same time, 8:30 to 12:30. We do appreciate you being here, and a big thank you to our TCA Premium and Elite members and our new DC members. We have made the Medicare hours a benefit of you being a new DC member of TCA. So again, thank you for being here. Please type in, if you haven't already, your name and your license number. That'll allow us to give you CE credit for today's webinar. I will mention that we also have our TCA West Texas conference coming up on March 27th, March 27th through 28th in Lubbock. It's in person, but it's also hybrid. So for your new DCs, you can get your TBC hours in that webinar virtually. So we want to help you get started with your career and with TCA. And so uh, I will go ahead and introduce you to our speaker, Lisa Majeski-West. Lisa has been involved in the chiropractic billing, management, and consulting field since 1982. We're talking about someone with a lot of experience in this, so I can think of few better to kind of help you understand Medicare. But in 2006, Lisa founded Gold Star Medical Business Services, which provides outsourced billing, compliance, and practice management consulting services for chiropractic physicians and medical practices nationwide. Lisa is a certified medical coder, medical insurance specialist, medical office manager, and certified professional compliance officer. She has taught for many medical and chiropractic associations, including Virginia, Ohio, Illinois, Indiana, Wisconsin, Arizona, Arkansas, South Dakota. You get it. But in Texas, because she's also from Texas, and we love having her on the stage and doing webinars for TCA. Um, Lisa is also presented very frequently with the American Medical Billers Association at several of their conferences and had keynoted. She also worked with Chiro Congress to start a national insurance help desk, which is available to TCA members. So if you guys ever have an insurance question, Lisa is the person. You can contact Lisa by email, and she is very quick to respond within 24 to 48 hours and answer any of your insurance questions. So, lastly, in September of 2023, Lisa was appointed by Governor Greg Abbott to serve on the board of the Texas State Office of Risk Management, which oversees the Workers' Comp Fund, auto insurance plan, trips for state employees. The mother of five children and three grandkids. I introduce you guys to Lisa Majeski-West. You guys have a great webinar. Enjoy. Thank you.
Thanks, Jeff, and everybody. Thank you for coming on a Saturday morning. I know that you know the weather here in Texas has been unusually nice. So the fact that you are sitting inside and are willing to listen to me for 4 hours is pretty outstanding. I'm pretty excited about that. I got a couple of housekeeping things that I would like to go over with you. I'm not going to go through my bio because Jeff did such a great job at doing that, but I do want to remind you guys that the Board of Chiropractic Examiners for the state of Texas does have a mandate that a licensee who is first licensed on or after September 2012 must complete at least 8 hours of continuing ed in coding and documentation for Medicare claims. So if you have not fulfilled that mandate, this course will do that for you if you attend both 4-hour sessions today and next Saturday. I do hope, because this is a webinar, that this isn't a situation where you log in and then walk away and have breakfast and go clean house and stuff like that. I do hope that you take the time to listen to this material because it is very important. It's very important to be compliant with Medicare. So I hope that I can keep your attention long enough to have you sit with me for the entire 8-hour session. I do also want to announce the antitrust statement. Sometimes these webinars and the conversations that we have in the webinars can get a little bit heated, especially when we start talking about all the rules that are being imposed on us by insurance companies, by the federal government. And you may hear things like, dang, we ought to just boycott Medicare and not see Medicare patients and not do this and not do that. And unfortunately, that actually is breaking the law. So we can't do that. We have to be careful about our discussions during the Q&A periods that we are going to have during the session to make sure that we don't have discussions or agreements on fixing prices. So if you ask me questions like, what should I charge for this or what should I charge for that? The only thing that I would be able to do is point you to the Medicare fee schedule and some other organizations that help you find the correct charges for your practice. We do not want to engage in conversations that say we should all go out of network or we should all boycott. We should all refuse to deal with third parties. We have to make sure that we don't do that. Those are actually against the antitrust laws of the federal government of the United States. Also, I'm going to be showing you some documents that are not government OMB documents. These are documents that represent things like maybe what you should have in your templates for exams and x-rays and things like that. Please understand that these documents are created documents by Gold Star Medical. And if before you use them, you want to check with your board of examiners or your attorney who handles the compliance of your practice. And finally, some of the information that you're going to see is coming from CPT code books, ICD-10 code books, and this is copyrighted material. I am using it just for educational purposes. All right. So the way things are going to work over the next 2 weeks is we have today's session, which is going to go from 8:30 to 12:30 for 4 hours. And then next Saturday, January 17th, 8:30 to 12:30 for another 4 hours. I have allowed time for Q&A after each major topical session. So once we get to the slide that says questions, what I will be doing is I'll be going to the Q&A box in the Zoom menu that is usually at the bottom of your screen. Some of you may have it at the top of your screen, but there is a little icon that says Q&A. Please use the Q&A for your questions and not the chat. This way I can handle those and make sure I'm addressing as many of the Q&A questions as possible. If you think of something during the session as I'm speaking, feel free to type it in the Q&A. We may have duplicate questions, and that's fine. But please use the Q&A to engage with me. There may come time, and Jeff, I don't know if there is a way to take participants off of mute or not in this particular session, but if there are, we may in the Q&A. You may put in, I have a question that's too long for a Q&A. Can I come off mute and ask the question? Please do that in the Q&A, and then we'll see if we can take you off mute so you can ask the question and we can engage in face-to-face conversation. I would love to do that with you guys. I know sometimes it's difficult in a webinar to really get a lot of engagement back and forth. So I want to try as much as possible to make sure that we can engage in a very meaningful way. We will take some short breaks during the session. About halfway through, we'll probably have a 10-minute break, a little bit of a longer break. And during that break, when you come back, you will have to re-log in through the chat box with your name and your license number. But if we do like a short potty break, you don't have to worry about that. I'll announce whether that break will require you to re-log back in or not. Handouts are available. I have posted the handouts in the chat box. So this entire slide presentation is available to you as a handout. So if you don't want to take copious notes, you can use the handouts as reference and feel free to print them. Also, if anything that I speak on or teach on brings up an issue or a particular problem with your practice that you do not want to share in the Q&A, and it's maybe sensitive in nature, I would be happy to do a free consult with any of you. I have the link right here on this slide that would allow you to click the link and use it to set up a free consult with me at your convenience. It would be about a 30-minute consult, and I'd be happy to talk to you about your particular needs or your particular challenges. As Jeff mentioned, we do have upcoming for the TCA, the West Texas Chiropractic Spring Conference in Lubbock, probably one of my favorite conferences to attend. Number one, because my son lives in Lubbock, but I do love coming up to Lubbock for this conference. It's usually a very lively one. And I will be speaking at this conference. The classes that I'm going to be teaching, I'm going to be teaching a 2.5-hour CE class on AI called AI, Your Superpower or Your Kryptonite. And we'll be talking about how to use AI to your benefit, what insurance companies are doing to use AI against you. And we'll be talking about possible solutions for that. And then I will also be doing a 4-hour CA session. So if you have CAs that need to be trained. Now, I do believe, Jeff, you may want to just type this in the chat. I do believe that this is not part of the hybrid. So we're in a completely different room. So unfortunately, this is not a virtual session. This is a completely live session. And it's called Do You Run Your Office or Does It Run You? So if you or your CAs really need some real robust training on office management, I will be in Lubbock on March 28th. It's going to be a Saturday session, and we'll have a great time. I love coming up there, and we usually have, again, a pretty lively group that comes in to listen to me speak on office management and office compliance topics. All right, are y'all ready? We are ready to get going. I see we have 34 participants right now. I do want to make sure that if you came in late, that you type in your name and your license number into the chat box so you can get the CE credits for this class. Okay, let's just get going. So what we're going to do is we're going to break this class up into some different segments. The first segment is just going to be an introduction to Medicare so that you have a full understanding of all of the different parts of Medicare and how they work together to form a comprehensive insurance for individuals who are over the age of 65 or under the age of 65 with certain disabilities. And then finally, individuals of any age who are diagnosed with end-stage renal disease. Now, this is end-stage renal disease is for individuals with permanent kidney failure requiring dialysis or a kidney transplant. So once they have CKD, chronic kidney disease, at a level 5 level of chronic kidney disease, stage 5, that means they have to go on dialysis or go on the list for a kidney transplant. They automatically become eligible for Medicare. Another condition in which a patient may become automatically eligible for Medicare without having to go through Social Security disability or go through the 2-year waiting period. So for those of you who may be familiar with this, for those who go on Social Security disability, if you're under 65, you become eligible for Medicare, but there's a 2-year waiting period. So you do not get Medicare right away. You start drawing disability benefits, but you still have to take insurance somewhere else. After 2 years, if your disability, then at that point, the Social Security Administration usually considers anything past 2 years to be permanent. Then at that point, you become eligible for Medicare. However, if you are diagnosed with ALS, you automatically become eligible for Medicare. So if you ever have a patient that you are treating and you fear that they may have ALS, and you can get that diagnosis confirmed, then they would automatically become eligible for Medicare. Medicare is basically, the Medicare program is basically under the auspices of CMS. CMS stands for the Centers for Medicare and Medicaid Services. And the Centers for Medicare and Medicaid Services basically throughout the United States provides health coverage to over 100 million people through Medicare. And we'll be looking at the statistics of how many individuals in the US actually have Medicare, Medicaid, CHIP, which is the Children's Health Insurance Program, and the Health Insurance Marketplace. So all of these entities fall under the oversight of CMS. Above CMS is the Department of Health and Human Services, and above the Department of Health and Human Services is the OIG, or the Office of the Inspector General. So CMS is not at the top of the pyramid. It's somewhere in the middle, and CMS is also falls, I'm sorry, under the Department of Health and Human Services. So once the Department of Health and Human Services also serves the Department of Education and some of the other government entities in the United States. So I'd like to start these sessions with with some stats and some metrics on what we are looking at in the state of Texas. And there may be some of you who are actually listening to this and you are not in the state of Texas. Maybe you are a non-member and you somehow found this webinar and thought, wow, this might be a really good one for me too. Now we're going to be talking about the state of Texas, but you can go to, if you are in a different state, let's say you're in Louisiana, for example, Arkansas, or one of our neighboring states like New Mexico, Colorado, you all fall under the same MAC as the state of Texas. You can go to data.cms.gov, and there is a tool that you can use to determine how many Medicare enrollees there are in your state. You can also find out how many enrollees have regular Medicare, which we call original Medicare, Medicare Part B, or Medicare Advantage. And you can even do it by county. So you can you can really drill down into the data to figure out how many Medicare enrollees you have in your immediate area that you potentially can serve. So I'm going to show you some comparisons. This is a slide, and I teach this Medicare class for the TCA every year. I have been for the last, I think, 4 years now. And in 2023, which is basically 3 years ago now, there were at the time 66 million enrollees in Medicare. Now, we talked about over 100 million total enrollees under CMS. So the rest of those enrollees make up Medicaid, CHIP, and the healthcare marketplace. But Medicare specifically has had in 2023 66 million total enrollments, with Texas representing 4,589,620 of those 66 million enrollees. Now let's fast forward to a year ago. Basically, we were at 68.5 million enrollees, and the Texas enrollments went up to 4,824,415 from 4,589,000. So within a 2-year period, we saw about a $2.5 million, $250,000 enrollee increase in the state of Texas alone. Now let's fast forward 11 months, or actually not 11 months, through December. Medicare enrollees increased to 69.4 million, all right? And Texas enrollees increased to 4,898,977. So we are almost at 5 million enrollees. And I would imagine that within the next year, we are going to surpass 5 million enrollees in the state of Texas. Now, I'm when we get to provider enrollment, the provider enrollment section, which is coming up in the next hour or so, we're going to talk, you're going to understand why this is important, because one of the things that we discover when we're talking to chiropractors is that there are many chiropractors who are not enrolled as Medicare providers, okay, or who say, I do not take Medicare patients. And yet many providers are also struggling, okay, with getting new patients into their practice. So when we look at this, one of the things we need to understand is that between May 2023 and September 2025, the total enrollment in the US for Medicare enrollees increased about 3.4 million. In Texas, the total enrollment increased in basically 2 years, 2.5 years, 309,000 people, more people, and it's going to continue to increase. People are living longer, right? Medicare never expected this. You know, back when Medicare was formed in the 60s, the average lifespan of a male was, I believe, 69 years old. It's now increased about 10 years. For women, it's even more. And so there are more and more people going on Medicare. And as you get older, and as if you're a young doctor and you're brand new in practice and you're just starting out as a new licensee and you're considering what to do with Medicare, please understand that by keeping Medicare out of your practices, you are essentially taking out about 15% of the total Texas population. So Medicare enrollees right now represent 15.2% of the population of Texas. All right. And so you have an immediate, if you're struggling with new patients, right? You could live theoretically find yourself with an immediate jump of about 15% in your practice simply by taking Medicare where you have not in the past. And I know that there are a lot of reasons why people don't take Medicare. We'll be talking about that during the provider enrollment section. We'll be talking about this if you are a cash practice and you're sitting here listening to me because you actually just have to take this Medicare thing, but you're thinking to yourself, well, I'm a cash practice, I'll never take Medicare anyway. We have some very important compliance information for you about that. So keep an ear out for some future lecture on this in the next couple of hours. So Medicare Advantage, actually, one of the things that we have to understand is that Medicare represents original Medicare, which is Medicare Part B, plus Medicare Advantage, which is Medicare Part C. And we're going to drill down into the different parts of Medicare here over the next few hours. But right now in the state of Texas, the split between Medicare Original and Medicare Advantage is 45% to 55%, and it keeps going up. So what that means is that 45% of the 4.8 million individuals in Texas have original Medicare, which is Medicare Part B. 55% have Medicare Advantage. And Medicare Advantage behaves very differently than original Medicare, as you will see through these next 8 hours. And we start talking about provider enrollment. We start talking about how to bill for Medicare Advantage versus Medicare Part B. You're going to see that there are some significant differences in these two models. And so it's very important for you to understand that. But the bottom line is, whether it's Medicare Advantage or original Medicare, you're looking at 15.2% of the population. Now, for the Medicare Advantage plans, which are commercial plans that administer Medicare programs, United Healthcare has 50% of the market share. in the state of Texas, and it really tracks also with the US. UHC has about 50% of the market share of all Medicare Advantage plans nationwide. Blue Cross Blue Shield of Texas has about 15%, Humana at 12%, and then the other 23% is a smattering of other plans like CVS Health, which is administered by Aetna, Cigna, and Baylor Scott and White. There are a few others out there as well that are kind of indigenous to maybe some different regions within the state of Texas that you may have heard of that, I don't have mentioned here, but it's usually a very, very small percentage. So right now, the total UHC enrollees for the state of Texas is about 4.7 million. And the Medicare Advantage enrollees, so total UHC. And the reason why we're talking about UHC is because I'm kind of prepping you down the road. When we get into the billing, we're going to be talking about this whole issue of having to get prior authorization for your chiropractic services through United Healthcare. So we want to really kind of outline and identify the fact that you're dealing with a lot of people here. So UHC Medicare Advantage enrollees in the state of Texas represent about 2.3 million individuals. And again, UHC has about 50% of the Medicare Advantage market share in Texas. Blue Cross Blue Shield has about 1.2 million enrollees in the state of Texas. They have currently 8 million enrollees all told. So that's their commercial plans, their federal plans, and their marketplace plans. But of those 8 million, 1.2 are Medicare Advantage enrollees. All right. So that kind of gives you a picture of how many Medicare patients we are dealing with in the state of Texas. Now what I want to do is I want to break down Medicare by the different parts of Medicare so that we can unpack this and help you understand what parts of Medicare you as a chiropractor are going to be dealing with. And so let's just kind of get started and we're going to just, I call it the ABCDs of Medicare. And let's get started with what we are going to be using in some of our visual aids to help you understand this. There is a government publication that comes out every year called Medicare and You. I strongly recommend that every chiropractic office have this downloaded, and possibly even if you take Medicare patients, you might want to make the investment in having it printed, placed in a binder, and put in your reception area in your practice. And the reason for that is because it very clearly helps patients understand their benefits with Medicare. It helps them understand the difference between Medicare Part B and Medicare Advantage. It's written in layman's terms versus government language. Now, Medicare has two websites, medicare.gov, G-O-V, which is the patient-facing side of Medicare. And that's where you will find this Medicare and You handbook under medicare.gov. It comes out every year, brand new handbook, so it updates with all of the newest regulations and whatnot. CMS.gov, all right, is the Medicare area for everything to do with Medicare, and this is where the providers can find resources and templates and aids to help them navigate Medicare billing and Medicare compliance. So CMS.gov is the provider-facing side of Medicare. Medicare.gov is the patient-facing side of Medicare. If you're a Medicare beneficiary, you're going to receive this publication annually. Now, Medicare, it used to be that Medicare would, sorry about that. It used to be that Medicare would mail these out, but in order to save money, what they do now is they send the beneficiaries a link to download this as a PDF and they can keep it on their computer. And then if they want to, they can print it as needed. But I have found that this particular um, publication makes it a great training tool for office staff and clinicians because it's written in very easy to understand language. So these are some of what you're seeing now moving forward are some of the visual aids that are actually found in the Medicare NU handbook. And basically I take snapshots of it and place these on my screen to kind of help us understand and unpack the different parts of Medicare. So let's start with Medicare Part A. Medicare Part A is hospital insurance, okay? And Medicare Part A is the part that helps cover inpatient care in hospitals and facility settings, such as skilled nursing facilities. Medicare Part A also governs hospice and home health care. So if a patient goes to the hospital and is admitted to the hospital as an inpatient, any type of hospital, whether it's a rehab facility, it could be an inpatient drug treatment center, it could be an inpatient rehab center for physical therapy, or it could be just a regular hospital, and they have Medicare, then their benefits are going to fall under Medicare Part A, and the billing will go out under Medicare Part A, which is a completely different claim form and claim process than Medicare Part B. Fortunately, for chiropractors, we do not fall under Medicare Part A. Physicians, chiropractors, physical therapists, and other types of providers like nurse practitioners and PAs do their billing under Medicare Part B. Now, Medicare Part A, for those of you who have ever worked in a job where you get a W-2, or you have W-2 employees, you know that with each paycheck, there is a small percentage, I think it's like 1.45 or 1.65% of a person's pay is withheld and placed into the Medicare fund, the Medicare trust fund. And if a person works at least 40 quarters in their lifetime before they become eligible for Medicare, so 40 quarters equals basically 10 years. So if you work for 10 years as an employee, you retire, okay, and you get Medicare, Part A becomes automatic upon reaching eligibility for Medicare. And you do not have to pay any premiums to obtain Part A coverage. So Part A is just included in your benefit as a retiree who has contributed at least 40 quarters of employee contributions. Now, if let's say all your life you've been self-employed, or you work in a profession in which that particular organization does not participate in Part A. For example, they have their own internal retirement fund for retirees, and there is a very important one in Texas that does that. We'll talk about that here in just a second. If those contribution requirements are not met, then Part A still is available, but the patient would have to pay a monthly premium to obtain Part A. So it's important to understand this. And again, this is something that, why do I need to know about this is because sometimes when you get an insurance card, a Medicare card, that red, white, and blue card, and this is probably going to be addressed in next week's session. We're gonna talk about how to recognize the different types of Medicare plans by the actual insurance cards. But it may say Medicare Part A, or it may say Part A and Part B, or it may just say Part B. So this would help you understand what type of insurance the patient has qualified for within the Medicare program. Now, Medicare Part A, although they don't have a premium that they have to pay, they do have deductibles for hospital stays and additional skilled nursing stays and so on and so forth. So, for example, if you are, let's say you have Medicare, you're admitted to the hospital as an inpatient, not observation, because observation falls under Part B, but inpatient falls under Part A. Then the first 60 days of your hospital stay, you pay a $1,736 deductible, and your hospital stay is covered at 100% after that. So, and that's the benefit period. Now, if you have to stay in the hospital more than 60 days, so between 61 and 90 days, you would have a $434 per day coinsurance for that hospital stay. And a lifetime reserve day after 90 days is $868. Now, under the skilled nursing facility, if a patient goes to the hospital, let's say they're in the hospital for 10 days, and then they get transferred to skilled nursing as an inpatient, the first 21 days of skilled nursing falls under their Part A stay. And if they haven't met their deductible, they would have to meet their $1,736 deductible. But if they have to stay in skilled nursing after past 21 days under Part A, then they would have to pay $217 per day. Now, what happens is that most patients who go to skilled nursing will have 21 days of Part A, and then they are released to Part B, skilled nursing, and then they start falling under Part B. So it's not usual that they pay past the 21 days unless it's absolutely necessary. All right, so probably enough said about Part A. Again, Part A is not something that you would be dealing with as far as billing or explaining patient benefits to one of your patients. However, for those of you who are thinking about, you're getting to that Medicare age, or maybe you have parents that are getting to that Medicare age, I think it's really important for you to understand what Part A means. Now, talking about Part A and going back to what I said as far as a certain profession in the state of Texas that does not contribute to Part A are the school teachers. So the public schools in the state of Texas are self-funded for Part A. And so retired school teachers actually have completely different insurance than another person would, because they did not contribute as a school teacher to Part A. The contributions go to a fund that is managed by the state of Texas. And we're going to talk about how to recognize, when we start looking next week at how to recognize those retirement plans, so you know how to properly bill for them. There are different alpha prefixes that you need to know so that you'll understand what those, who has those retirement plans and how to bill for them properly. Okay, so let's talk about Part B. So Part B Medicare helps cover services from doctors and other healthcare providers, and that's you, the doctor of chiropractic. And please understand that according to Medicare and CMS, there are two types of providers. You have physician and non-physician. You are considered a physician under Medicare standards, okay? You are not considered a non-physician. Non-physicians are physical therapists, occupational therapists, speech therapists, nurse practitioners, PAs. Those are considered non-physician providers, registered dietitians, and so on. And so you are on the physician side, so you fall under Medicare Part B. Medicare Part B also covers outpatient care. So if a patient has a day surgery, or let's say they are in an outpatient type of treatment facility, like a physical therapy facility, and they're going 3 times a week for physical therapy, that falls under Medicare Part B. There are also certain home health care services, like professional services by physicians, because home health is nursing care, okay? So anytime home health requires a physician to come in, that falls under Part B. And then also durable medical equipment, so things like wheelchairs, walkers, hospital beds, and other types of equipment, braces that may be, you know, given to patients, that also falls under Medicare Part B. And then also preventative services like colonoscopy screenings, pap smears, shots, vaccines, and then the yearly annual wellness visits that Medicare pays for at 100%. Now, one of the misnomers is that Part B is optional, okay? That is actually not true. Part B is automatic upon reaching eligibility for Medicare. So if you are, let's say you're 64 years old, you start getting a lot of emails and a lot of ads about signing up for Medicare. And you're thinking, well, I'm still working full time. I don't want Medicare. That doesn't matter. You will automatically be placed into Medicare Part B, and you will automatically start having premiums deducted from your Social Security check, or you'll have to start paying premiums unless you opt out. So you have to physically opt out of Medicare Part B if you don't want it. And so you can delay Part B eligibility while you're working full time without penalty if you want to. You just have to let Medicare know, no, I don't want Part B at this point. I am still working full time. Sometimes you may want Part B because Part B benefits are better than your employment benefits. And then in that case, Medicare may become your primary payer, or it may become your secondary payer. And we're going to talk about that as well when we start talking about coordination of benefits later on down the road in this session. It does require an additional monthly premium, and it requires a patient to either opt out or to replace coverage. So replacing coverage would be a patient opting to go from a Medicare Part B plan to a Medicare Part C plan, which is Medicare Advantage. All right. The monthly premiums for Medicare Part B are based on income. They're income based. So not every patient has the same premium. Now, the amounts in red that you see on the income level, okay, and this is your modified adjusted gross income. So if you are married filing jointly, which are the numbers in red, okay, the numbers in black, the $106,000, is if you're filing as a single. So if you are, let's say you're a widow or a widower, or your patient is a widow or a widower, and their income is less than $106,000 a year, then their 2026 Part B premium is $202.90 a month. Okay. If you're married filing jointly, husband and wife are still alive, and their Maggie is less than 212,000, it's $202.90. And you can see that as the income increases, so does the 2026 premium. So, someone in the range of, 133 to $167,000 as an individual is paying about $405 in Medicare Part B premiums. Okay. IRMA, IRMAA, stands for the income related monthly adjustment amount, which represents the sliding scale for the premiums. The Medicare Part B deductible for 2026 has gone up from $257 to $283. So for those of you who treat Medicare patients, the first $283 of covered charges, and that's important to understand, is it is for only for covered charges. So if you're billing or you're treating patients and you are treating patients with things like shockwave or e-stim or exams, things that aren't covered by Medicare Part B under the chiropractic benefit, that does not apply to their deductible. Only the spinal manipulation codes for active treatment apply to the deductible. The deductible is $283. Now, most Medicare patients meet their deductible probably by the end of January because they usually use that first part of the year to go see their doctors and get their checkups. And now the annual wellness visit is not subject to the deductible, but any specialist care would be. So $283 is the 2026 Medicare Part B deductible. Now, if you are watching this, I know that the TCA is going to be placing this on their website for future viewing. And if you're watching this and it's a different year, all of these numbers are going to change every single year. So it's very important for you to make sure that you know what the annual deductible is each year. We're going to skip Part C right now, and we're going to move into Part D, drug coverage, and then I'm going to swing back around and we're going to talk at much more length about Part C. So Part D, drug coverage, when Medicare first came out, all right, original Medicare did not cover drugs. And honestly, the reason for that is because people didn't really take drugs that much. And the drugs that they did take were things like, um, antibiotics and, maybe there were some, for some serious conditions, there would be Part D drugs or there would be drugs that they would have to pay for out of their pocket. So patients did not have Medicare patients did not have the ability to have a drug plan for many, many years. And Medicare formed Part D, I believe it was in the late 90s or early 2000s, to help cover the cost of prescription drugs. And what happened was, once that happened, is prescription drug prices shot up, completely went out of control. And so patients do now have the option to pay an additional premium to get drug coverage. And plans that offer Medicare drug coverage are run by private insurance companies that follow rules set by Medicare. Now, patients who enroll in original Medicare and they do not choose a Medicare Advantage plan will usually pay an additional premium for drug coverage. And these premiums can range anywhere from, $20 or $30 a month on up to, it could be up to like $100 a month more for drug coverage. All right, so we've talked about Medicare A, we talked about Medicare B and D. So now let's take a little step back and talk about Medicare Part C, which is also known as Medicare Advantage. Medicare Advantage plans will are managed by private insurance companies. So this is basically private insurance Medicare. And these will provide, and typically what Medicare Advantage plans do is they roll A, B, and D into one plan for patients. So patients who have original Medicare Part B, and that's what they elect to do, will often have to pay pay for a supplemental insurance because Medicare Part B is a straight up 80-20 plan. There's a $283 deductible. After that, Medicare covers 80%. Medicare Part B covers 80% of allowable charges. And then there's that 20%, which, for spinal manipulation, okay, maybe that's $7 or $8, but for more significant, like hospital stays, surgical procedures, if you're getting billed a $10,000 procedure, that's $2,000 out of your pocket on an 80/20 plan if you don't have supplemental insurance. So what we see is that a lot of patients will have, for if they choose original Medicare, they actually have three plans that they're paying for: Medicare B, Medicare D, and then a supplemental plan. So they have to manage three different premiums. So one of the things that's very appealing to patients is that they don't have to do that anymore with Medicare Part C. Medicare Part C covers their hospital, covers their drugs, and covers their physician office visits. Very similar to regular commercial insurance that they were used to having before they became eligible for Medicare. The other thing about Medicare Advantage plans is that because Medicare Advantage plans are managed and operated by commercial insurance companies, these commercial plans try to be very competitive with each other. And so oftentimes what they do is they sweeten the pot for these Medicare Advantage patients and offer additional benefits. So they may offer things like, for chiropractic, they may offer to pay for the exam. They may offer to pay for physical therapy. They may offer to pay for maintenance care. And so patients with Medicare Part C plans that have elected to have expanded benefits may actually have more benefits, chiropractic benefits, than if they have a original Medicare. And again, we're going to get into much more detail about this when we talk about billing and we talk about coding for Medicare Part C. Private insurance companies that are approved by Medicare will run these plans. Now, generally, you have to, meaning you, and remember, what you are seeing is coming from the Medicare and You periodical. And you, meaning you, the patient, must see doctors in the plan. So what that means is that you, the provider, in order to see a Medicare patient in a certain plan, would need to be enrolled in that plan. Now, we're going to talk about whether there are out-of-network benefits for Medicare Advantage patients, and in some cases there are, but most of the time, the patient is going to have to see a doctor who is in the plan. Very, very similar to commercial insurance. Most Medicare Advantage plans will cover prescription drugs, and or you can choose the Medicare Advantage plan without prescription drugs and pay a monthly premium. So the Medicare Part B premium does not go away when a patient goes to Medicare Advantage. What some Medicare Advantage payers do is they waive the premium for their beneficiaries. So this is where you may see the ads that say, if you choose this UHC, plan, HMO plan, you have no premium. All right. It's not that that they don't have to pay their Part B premium. They do, but the Medicare Advantage payer absorbs that premium so the patient doesn't have to pay it. Again, it is a way to be competitive with Medicare Part B and other Medicare plans. Now, some Medicare Part C plans that are kind of the better plans that have better coverage will have premiums. And in some cases, those premiums are really no different than the Medicare Part B premiums if the patient had B, D, and a supplemental plan. So it's just one of those things that patients have to be aware of. Okay, so we've talked about the different parts of Medicare. Now let's look at the comparison between original Medicare, which is Medicare Part B, and throughout our talk in the next couple of sessions, I'm going to be talking about original Medicare as red, white, and blue Medicare, because red, white, and blue is they get every patient gets a red, white, and blue card, Medicare card, when they become eligible for Medicare, whether they have Advantage plans or not. If they have an Advantage plan, they may also get another insurance card. But every patient gets the red, white, and blue card. That's original Medicare. I will also refer to original Medicare as Part B. So anytime I say Part B, I'm talking about original Medicare for your, just so that you understand. Medicare Advantage is Part C. So for original Medicare, the patient can use any doctor or hospital that takes Medicare anywhere in the US, right? Now, if the provider is an out-of-network provider with original Medicare or non-par, and when we get into provider enrollment, we're gonna talk about the differences. The patient may pay a little bit more if the doctor doesn't accept assignment on the Medicare claims, which you do have the ability to do that, to be non-par, not accept assignment. Most doctors are par. It is probably a 90-10 split of par versus non-par providers, but we actually do have that split is probably higher in chiropractic, where more chiropractic providers are non-par than the national average. Okay. Original Medicare is taken in the 50 states, DC, Puerto Rico, the Virgin Islands, Guam, the Northern Mariana Islands, and American Samoa. So original Medicare is covered in all of those states and regions. Now, Medicare Advantage is a little bit different. So in Medicare Advantage, the patient may need to see doctors or providers who are in the plan's network and service area. And this is really important for you guys to know. And give me a minute or two, and I'm going to have a slide about this, because you're going to have patients who ask you questions about, should I go with Medicare or should I go with a Medicare Advantage plan? And you need to know how to answer that. So the majority, I would say 98% of Medicare Advantage HMO plans are what are known as service area plans, which means that the patient has to choose, in order to get any benefits at all, the patient has to choose a provider in their service area, and their service area could be their county. All right, that's how restrictive it might be. So if you have a Medicare patient, let's say you're in South Texas, you're in the McAllen area, and you're listening to this, and you have a patient who comes in as a snowbird from Minnesota, and they come down and they bring their RV down to McAllen for the winter, and they come and see you, and they've chosen a Medicare Advantage plan that is a service area HMO in Minnesota. They have no benefits in McAllen. So it's real important for you to know that and understand that anytime you see the word HMO on a Medicare Advantage card, you should have little alarm bells, or your staff should have little alarm bells going off saying, ooh, okay, this is an HMO plan. Are we providers in this service area? Because if we're not, there may be no benefits at all, and you would have to notify the patient about that. The only thing a patient can get if they have an HMO plan and they're outside of their service area is emergency care. So they would have to go to the ER and receive emergency treatment, and then have to go back to their service area for routine medical services. All right. So now some plans do offer non-emergency coverage, like the PPO Medicare Advantage plans, but typically it's a higher cost. So this is one of the things that unfortunately, many Medicare Advantage patients don't understand, is that they're looking at it from an economic standpoint, totally understandable. You know, many of these Medicare patients are on a fixed income, so they're thinking about how I can save money. But they have to understand that they may not be fully covered if they go outside of their service area. They may not be covered at all if they go outside their service area. The other difference between original Medicare and Medicare Advantage is that in most cases, the patient doesn't need a referral to see a specialist. They can go see whoever they want, whenever they want, as long as that provider is a Medicare provider. Okay, they can, if they're snowbirds, and they have original Medicare, that original Medicare works in Minnesota, it works in McAllen. It doesn't matter. But with Medicare Advantage, they may have, just like other HMO plans, they'll have a PCP, which is a primary care physician. That primary care physician, they'd have to go see the PCP, say, I want to go see the chiropractor. The PCP sends a referral over to you. You also have to be in the network in order to see that patient. So the patient may need to get a referral to use a specialist, and the specialist also has to be in their network. So you can see how, in comparison of original Medicare, Medicare B to Medicare C, there are some differences in the restrictions on the patient's benefits. There are also different cost variations. So for Part B, the patient has to pay 20% of the Medicare approved amount after the deductible is met. That amount is called the coinsurance. In Part C, those costs vary. The patient may have a copay. They may have a deductible. They may have both. They may have a copay for exams, and they may have a deductible for other types of procedures. Okay. As far as the cost, this is where it becomes appealing for the patient to choose Part C. So you can see that in Part B, they have the monthly premium, again, based on IRMA, based on the adjusted, the modified adjusted gross income. They're going to have a premium. Then they may also have an additional premium for a drug plan, and they may also have an additional premium for Medigap insurance, which actually covers all or part of that 20% that Medicare doesn't cover. And we'll be doing a comparison of the different Medigap plans here in a little while. Okay, so the patient has a Medigap plan. They may, for Part B, Medigap, Part D premium, and then the Part B premium, that can add up quite a bit. Under Medicare Advantage is they pay the Part B premium and the plan's premium in addition to that, but some plans have a different premium and may help pay all or part of your Part B premium. So they give essentially a refund back. They don't give it to the patient, but they give an incentive to the patient to choose that Part C plan. But remember, nothing is free. So the patient, may not have to pay a premium each month, but when they do need to receive medical care, there's going to be some restrictions on that medical care, and there may be additional costs that they'll have to pay. Most of the Part C plans will include drug coverage. So again, they don't have to pay a Part D premium. In Part C, there's no yearly limit on what they pay out of pocket. So basically, there's no out-of-pocket maximum. For those of you who don't know what an out-of-pocket maximum is in commercial plans, we see these all the time. An out-of-pocket maximum means that there's a certain amount, a threshold, that once the patient pays this much out of pocket, so let's say the patient's out-of-pocket maximum is $1,000. Once they pay that amount, then their insurance is covered at 100%. They have no copays, they have no deductibles, they have no more co-insurance amounts. Original Medicare has no out-of-pocket maximum threshold. So they have to pay that 20% forever. There's no period of time in which that's capped and then it reverts to 100%. They can cover that 20% with Medigap insurance. But with Medicare Part C, they will generally have an out-of-pocket maximum, yearly limit on what you pay for services. Now, these could be different for in or out of network. Once the patient reaches the plan limit, they pay nothing for covered services for the rest of the year. Now, here's the other big difference between Part B and Part C. In Part B, the patient can choose to buy Medigap, which is a supplemental plan to help pay those out-of-pocket costs that Medicare doesn't cover, like the 20% coinsurance. Or you can use coverage from a current or former employer or union plan or Medicaid if they qualify to gap the coverage. That's why it's called Medigap. It gaps that opening of coverage that the patient normally has to pay. Now with Medicare C, they cannot buy Medigap. All right. Now they can use coverage from a current or former employer or union or Medicaid, but most of the time, patients who have Part C only have Part C. They don't have a secondary. And this becomes very, very important when we start talking about coordination of benefits next week. All right, let's talk about coverage. So under Original Medicare covers most medically necessary services and supplies in hospitals, doctors' offices, and other healthcare services. Now, there are some services like routine physical exams, eye exams, and dental care that are not covered under Original Medicare. However, Medicare Advantage plan may offer extra benefits that Original Medicare doesn't. Again, like vision, dental, expanded chiropractic services, and so on. For Original Medicare, the vast majority of medical services and procedures do not need prior authorization. There are a few exceptions, like in certain DME, and then certain high dollar items would require prior authorization. Also, certain states have a model that is being implemented right now called the WISER model. Texas is actually in the WISER model for some of the high dollar items that do now need prior authorization. Under Medicare Part B, however, a lot of procedures require prior authorization, including chiropractic care. So in a fair number of cases, if you have a Medicare Advantage patient, you may have to submit for prior authorization on behalf of that patient for them to receive chiropractic benefits. And again, when we get into the actual billing compliance, we'll talk about that in a lot more detail. Patients will generally under Original Medicare will have to join a separate drug plan to get drug coverage. Under Medicare Advantage plans, it usually includes drug coverage and you don't have to join a separate Medicare drug plan. And then finally, under foreign travel, neither Medicare or Medicare Advantage plans cover foreign travel. However, some plans could offer extra benefits that cover emergency services. And there are a couple of Medigap plans that cover emergency care outside of the US. So if you are of Medicare age, your patient, maybe your parents are coming into Medicare age, or you have Medicare patients who are asking you about, what type of plan should they choose? That would be one of the questions you would want to ask them is, do they travel outside of the US or outside of the service area? All right, so one of the things that's really important to do when you're dealing with Medicare versus Medicare Advantage is your patients, a lot of them don't know themselves what they have. They don't know if they'll say I have Medicare, they may have Medicare B, they may have Medicare Advantage, they may have a supplemental plan. And so it's important for you to identify Medicare Advantage plans on an insurance card because that is going to tell you who gets billed first, okay? So when you look at the patient's insurance cards, if you see anything that says Medicare Advantage, Or it says Medicare Advantage HMO, MSA, Medical Savings Account, PFFS, POS, PPO. These are all Medicare Advantage plans. If it says MA, it usually means Medicare Advantage. Um, and so you want to pay particular attention to that. Now, some of the Medicare Advantage PPO plans will have, and actually this also goes for commercial non-Medicare insurance, that if the insurance card has a suitcase, little icon on it that is a suitcase, and inside the suitcase it says MA or it says PPO, that means it's a traveling plan. It means that that plan can be used outside of the patient's service area. So that's one way to quickly identify if you have a patient coming in from a different state who has a Medicare Advantage plan. You would want to look at that very carefully. And if they have a suitcase that says PPO, they actually may have benefits in your service area. All right. So to compare Medicare Advantage and Medicare Part B in a nutshell, original Medicare covers Part A and Part B. And then in order for that patient to be fully covered, they could add Part D, which is the drug coverage and the supplemental coverage or the Medigap plan. Okay. Or they can use coverage from a former employer or union, or if they are Medicaid eligible, they can use their Medicaid plan as their secondary plan. Medicare Advantage rolls all of that into one plan with one premium or even no monthly premium. So before we get on to our next topic, you're going to have patients who ask you, what should I do? And especially towards the end of the year when they are thinking about when there's an open enrollment period, that's usually October 15th through about December 7th of each year. They are bombarded with ads saying, hey, enroll in this plan, enroll in that plan, or maybe they are new, they're new to Medicare, they're about ready to join up with a Medicare plan, and they don't know what to do. They don't know if they should stay with original Medicare or go with Medicare Advantage. One of the things that I would recommend that you do, number one, is don't just say, oh, don't go with Medicare Advantage. They're terrible. They don't have any benefits. They don't have this. They don't have that, right? That's actually an antitrust violation. So I'm trying to keep you guys safe. So avoid bashing Medicare Advantage plans, okay? What you want to do is say, look, all I can do is give you the pros and cons, all right? And I can tell you that if you were my mom, this is probably what I would say. All right. So if you were my mother, this might be how I would advise you, but um, give them the pros and cons, right? And the pros, and it's a big one, is acknowledge to the patient, look, these Medicare Advantage plans are usually more economical from an out-of-pocket standpoint on your monthly premiums. You're going to pay one premium for everything, and some Medicare Advantage plans even give you a break on that, so you don't even have a monthly premium. Okay, so yeah, that is definitely something to consider depending on your budget. But please understand that the budget Medicare Advantage plans are usually HMO plans that are geographically restrictive. So ask the patient, do you travel a lot? Do you have multiple homes in a different state? So do you have a home in Minnesota and a home in McAllen, or do you have a home in New York and a home in Florida? Do you have a home in Texas and then you go, to California for the winter to be with your kids? Because if you do, you want to make sure that you choose a plan that will work in both places. Or if you like to travel, if you're an RVer and you travel the country in an RV every winter, and you go through the entire southern region of the country, do you have coverage for to account for illness or injury if you're in a different area other than your service area of that HMO. If you're going to travel, then you would want to consider Medicare Part B or a Medicare PPO plan that would travel with you, okay? Stay away from the HMO plans because those aren't going to work everywhere. They're only going to work in your service area, okay? The other thing patients need to know is that if they enroll in a Medicare Advantage plan and they want to come back to original Medicare at any time, they'll pay a lifetime penalty of the difference in the premiums that they didn't pay for the Medicare Advantage plans versus, they'll go back for as many years as they didn't pay premiums, and that will be tagged on to their premiums in original Medicare. So they may pay a lifetime penalty, and that'll be for the rest of their lives that they'll have to pay that penalty. So once they choose the Medicare Advantage route, it becomes cost prohibitive for them to go back. All right. Patients enrolled in Medicare Advantage plans also will be more likely to need prior auth or PCP referrals for procedures and specialist Medicare services. Ask your patients, do you want to deal with that? If not, you may want to go with a PPO plan that doesn't require auths, or you may want to go with stay with original Medicare. Okay. Premiums are lower in the Medicare Advantage plans, but out-of-pocket costs may vary. And depending on the plan, the sicker you are, the more it may cost you to use those Medicare Advantage plans. So this is what you would tell them, okay? And again, be careful to just not categorically make a statement saying, oh, no, don't do the Medicare Advantage route. That's terrible. Because you know what? Then they go to their insurance agent, and their insurance agent hears that you said that, and then you get accused of an antitrust violation. We certainly don't want that for you, okay? All right, I'm going to open up the chat to see if anybody put any questions in. I do not see that. Let's look at the Q&A. Brian Long says, I'm a cash practice with the exception of non-par, not accepting assignment Part B. I don't have plans to bill any other insurance in any shape or form. Can I still see Part C patients as a cash patient if they're willing to pay out of pocket? That's a great question. And actually, we are going to go through this when we go into the billing and coding section of of the session. The long and short answer is yes and no. So you can see the Part C patients as a cash patient if they have a Medicare Advantage plan with no benefits. So for example, if it's a Medicare Advantage PPO plan, and they have no out-of-network benefits, then you verify benefits. You basically tell the patient, we have checked your benefits of your Part C plan. It's an HMO plan in which we don't participate. And because of this is an HMO plan, there are no out-of-network benefits if you see a non-par provider such as me. So then at that point, we can treat you, but we would have to treat you as a cash patient. Okay. Now there is a little caveat. If the patient has a Medicare Advantage PPO plan and there are out-of-network benefits, because you are a non-par provider with Medicare, all right, you would be non-par with that PPO plan. And if there are benefits for the spinal manipulation and there are any extended benefits like for exams and x-rays, then you would be bound to bill that PPO plan, but you don't have to accept assignment. So we'll talk about the widgets of that when we get into the billing and coding part of it. But the answer is generally yes. You don't, you're not going to have to bill Medicare as an out-of-network provider for the Part C plans, because honestly, the vast majority of your patients are going to be HMO plans. That's why they chose Medicare Advantage, is because they don't want to pay those monthly premiums. And so most of the time there are no benefits, so you don't have to, you don't have to uh, bill Medicare for those out-of-network plans in which there are no benefits whatsoever, okay? Are there separate, Deborah White states, are there separate deductibles for a supplement and drug plan with original Medicare? Sometimes there are. Now, the drug plans have a standard deductible by Medicare. I'm not exactly sure. The rules change from year to year. So usually what there is under the drug plan, the first so many dollars of these different drugs are covered at 100%. And then there's like this donut hole where there's a deductible. It could be like 1,000. I don't know what it is this year. I did not check on that. And then after that, deductible is met, it's covered again at 100%. So the patient gets a benefit um, uh, at first where they don't have a deductible, then they have a deductible, and then they don't. Sometimes the patient will have a deductible for a higher tier drug. So, if they're taking like an anti-rejection medicine, they may have to pay a deductible for that, depending on their plan. And also remember, some drugs are covered under Part B. So like chemotherapy drugs are covered under Part B and not under Part D. So it's important to know that. Some supplemental plans will have a deductible as well, but most of them do not. Most of them are just they just start paying the premium for the supplemental plans. Okay. Let's see. Are there any other questions? I do not see. Does anybody want to come off of mute and ask a question? All right. So it is 9:52 right now. Let's take just a little 5-minute break, and then we're going to get on to our next session after that. We'll come back it's 9:53. We'll come back at 9:58.
Miss Lisa, someone put a question in the chat. I'm just gonna ask them to please put that in the Q&A.
Okay, great.
$2,100 maximum out of pocket. Yeah, yeah, I knew it was 6 something.
Mhm.
Yeah. Mhm.
All right, we're going to get started again. There were two Q&As that, are we still recording? Just want to make sure.
Yes, ma'am. It should be recording the entire
Fantastic.
session.
Okay, great. Just wanted to make sure there, the question in the chat, oh, I didn't see it. I guess it's, okay. So let's talk about Medicare provider enrollment. And and there is importance to this. So it is important for you to understand as a chiropractor your responsibility to being enrolled in chiropractor in Medicare, sorry. So in order for you to treat Medicare patients, okay, you have to be enrolled in Medicare. And that goes for treating original Medicare patients and Medicare Advantage patients. You'll also find that if you're wanting to take regular insurance, commercial insurance, one of the first questions that's asked in the credentialing process is, do you accept Medicare patients? And some commercial plans may require that you be enrolled in Medicare as a condition for participation in those plans. Okay. You also have to be enrolled in Medicare B, original Medicare, to get in network with Medicare Advantage plans. So that's one of the aspects of Part B enrollment. Now, the other, which is significantly more important to understand, is that doctors of chiropractic at this time, all right, and again, this is as of January 10th, 2026, cannot opt out of Medicare. So what does that mean? What that means is that chiropractors, by law, are not permitted to enter into a private contract with a Medicare patient. You cannot use an ABN form to treat Medicare patients as cash patients unless you're enrolled in Medicare, okay? You cannot treat Medicare Advantage patients unless you're enrolled in Medicare. And I don't mean, bill, I mean treat, I mean see them at all, whether you're seeing them as a cash patient or not. You cannot bypass this rule by only treating maintenance patients. And you can't bypass this rule by only billing for non-covered services. So here's the scenario that I come across, unfortunately, more frequently than I care to, than I hope for, okay? Um, and and here's what happens. I talk to doctors all the time. We have a billing company, and we have about 150 practices that we do billing for throughout the US. And we have many practices in Texas. I'm a resident of Texas. I live in Horseshoe Bay. And so I get to talk to a lot of chiropractors, and I have over the 43 years that I've been doing this. And and I'll be talking to them, and I'll ask them about their payer mixes or whatever, and they'll be like, "Oh yeah, we we're in network with Blue Cross, but we don't take Medicare." I'll be like, "Okay, so what does that mean?" And they're like, "Well, you know, we um we only see maintenance patients. We don't do any active treatment of Medicare patients." Well, okay. Do you have a Medicare number? Have you enrolled in Medicare? No, we just, what we do is we just have the patient sign an ABN form that they're going to be a cash patient, and then we just treat them as a cash patient. Or they say, well, we don't do spinal manipulation. We only do shockwave, and we only do therapy on the patients, and that's not covered by Medicare, so we can do that. And that could be, there's no truth to any of that, okay? The law is very clear that chiropractors cannot opt out of Medicare. So what this means is that all of the ways that I see chiropractors try to bypass the opt-out provision, okay? So there are essentially three options of participation in Medicare. You can be a par provider, participating provider, a non-par provider, which is non-participating, or out of network. We can use out of network, in the same language as non-participating. So you can be an in-network or par provider, an out of network or non-par provider, or some providers do have the ability to opt out. And opting out means you write a letter to Medicare that says, I no longer wish to participate in Medicare, and I am going to enter into a private contract with a Medicare patient, meaning I'm going to have the patient sign a contract that says, I agree not to have Medicare billed for any of my services, and I'm just going to pay cash, all right? Unfortunately, chiropractors are in a group of provider types that are not permitted to do this. So essentially, those chiropractors who tell me, oh, well, I just use the ABN form and I have them, choose option 2 on the ABN, which basically says, don't bill Medicare, I'll pay cash. You're entering into a private contract. That's your way of entering into a private contract with a Medicare patient without a Medicare number. So very, very important to understand that chiropractors do not have, and this comes directly, what you're seeing on your screen comes directly from the Medicare claims processing manual, all right, that gives a bullet point of providers that are eligible to opt out and providers who are not eligible to opt out. It's a small group, and chiropractors are in that group, okay? So you have to understand that you are in a group in which treating Medicare patients without a Medicare number is literally against the law. Don't do it, okay? Your option, if you don't want to take Medicare, is don't take Medicare patients. So that's the option. If you say, look, I don't care, I do not want to I don't want anything to do with Medicare, right? I don't want to be enrolled in Medicare either as a participating or a non-participating provider. You do have that option, but what that means is you can't see Medicare patients. And if you have patients that later on in your career age into Medicare, you have to refer them out of the practice, okay? If you have patients who have Medicare Advantage plans, you may not see them, so you can't see them. You can't see Medicare Advantage plan patients either. So if you are in that category of providers who never got a Medicare number, right? and you are seeing Medicare patients, then you're on the wrong side of the law. I mean, I really can't say it more plainly than that. And I don't, look, I'm not the kind of compliance person that likes to be an alarmist, but this is one that I see so often misused and misapplied. So please, please understand that. And this is why I go through a provider enrollment section in my Medicare classes, because it's very, very important for you to understand your responsibility to Medicare if you are planning on seeing Medicare patients in any way, shape, or form. So your enrollment types are you enroll as what are my options? Okay. You can enroll as a PAR provider, meaning you agree to accept Medicare patients. You agree to accept assignment. Now, what that means is you agree to bill Medicare for the covered services and wait for Medicare to pay you, right? So you don't collect upfront from the patient. You agree to accept the fee schedule for the covered services that Medicare covers, and you agree to bill Medicare for those covered services. All right. Now, the good thing about that is Medicare only covers three codes. They only cover spinal manipulation for active treatment to correct a subluxation. And when we get into this afternoon, or actually later this morning, when we get into the section on coverage of chiropractic and your documentation requirements and that type of thing, you'll understand as being a PAR provider gives you a lot of freedom to treat your patients really any way you want. And you really only have to bill for those three codes when the patient is under active care. All right. Now, as a non-PAR provider, you also agree to accept Medicare patients. You do not have to accept assignment. Okay. So what that means is you can have the patient pay for their active treatment codes up front. You would collect what's called the non-PAR limiting charge for those covered services. And I'm going to have the fee schedule posted here in just a few minutes. You agree to bill Medicare for covered services. So you still have to bill Medicare as a non-PAR provider, but when you file the claim non-assigned, and then Medicare essentially reimburses the patient and does not reimburse you. Okay, so you can enroll as a PAR provider, or you can enroll as a non-PAR provider. All right. Now, this is as of January 1st of 2026. This is the Medicare fee schedule. And I pulled this from Novitas Solutions, which is the Medicare administrative contractor for the state of Texas. I based this on Texas locality 99. There are actually 8 different localities in Texas. 99 is the rest of Texas. So the other 7 localities represent urban areas like Houston, Austin, Dallas, Fort Worth. Okay. Everywhere else, like West Texas, Lubbock, down South Texas, you're going to be in Texas locality 99, or if you're anywhere outside of these urban areas, and it's by county, okay? This is what your fee schedule is going to look like. Now you'll see that you have the PAR fee, the non-PAR fee, and the LC. The LC is the limiting charge, okay? So the limiting charge is the maximum as a non-PAR provider, you can charge the patient if you don't accept assignment, okay? Now, you can accept assignment as a non-PAR provider, but actually you get paid less if you do that. Your reimbursement from Medicare is at 95% of the PAR rate. So there's really no upside to being a non-PAR provider and accepting assignment other than you're giving the patient a break in having to pay up front for their services, but you're the one taking the 5% pay cut. Under the limiting charge, you can actually charge more than the PAR fee, all right? So you'll see the difference. So the 3 codes that are covered as we'll discuss again, again in more detail in the billing and coding section next week, is the three codes that are covered to correct a subluxation, which is the 98940, the 98941, and the 98942 codes. All right. So for the rest of Texas, if you're a PAR provider and you're billing a 98941, your allowable is 3761, 98940 is 2611, and 98942 is 4882. And then for the non-par limiting charge, for the par rate, or the non-par rate limiting charge for 98941 is 4109, and so on and so forth. Okay. And remember that the limiting charge only applies when you choose to not accept assignments. So the patient pays up front, and that is the maximum that you can legally charge a beneficiary when filing an unassigned claim. Now, one of the things that you're going to notice about my slides is when I'm teaching, especially when I'm teaching Medicare and compliance, is I will always try to give you the source of the document. So if you're like, well, I want that in writing, you've got it. I'm sending you, I'm giving you the sources right there on the slide. Okay. So how does a non-par provider get reimbursed? The patient pays the limiting charge for the covered service. The provider bills Medicare up to the limiting charge as a non-assigned claim. Then the patient is reimbursed by Medicare, but they're reimbursed based on 80% of the par rate after their deductible is met. Okay, so how does that look like in the math? We're going to look at the rate of 98941, okay, based on an in-network allowable, par allowable of 3761, which is the fee schedule for the rest of Texas, okay? If you're a par provider and you're billing 98941, Medicare is going to reimburse you 80% of 3761 after the patient's deductible is met, or $30.08. Now, there are some other, there's a 2% sequestration reduction. There may be reductions based on the quality payment program, additional reductions, but just from the fee schedule alone, that would be your reimbursed rate, okay? Patient would pay 20% or $7.52 after they meet the $283 deductible, okay? Now, if you go the non-par route and it's a non-assigned claim, you can charge the limiting charge of 4109, all right? The provider is paid 4109 up front by the patient. You bill Medicare on behalf of the patient. You still have to bill Medicare and do the billing, but you file it as a non-assigned claim. Medicare reimburses the patient 80% of the 3761 after the deductible is met. So the patient is reimbursed 3008, and the patient, essentially, their net responsibility becomes 1101 versus the 752 if they were to see a par provider for the same service. Now, the non-par, if you assign your claims as a non-par provider, which again, I don't see the upside to it, the limiting charge doesn't apply. Basically, you then are reimbursed at 95% of the par fee schedule. So 95% of 3761 is 3573. Then you get 80% of that, or 2858 less the sequestration and the QPP adjustments. So you can see that the difference in the reimbursed amounts, depending on whether you're par, non-par, or non-par, non-assigned, or non-par assigned. So ultimately, what are your options? Your options are to enroll as a participating provider with Medicare, enroll as a non-par provider, don't enroll and don't accept any Medicare or Medicare Advantage patients. And if you don't enroll, refer your existing patients out when they become Medicare eligible. Those are your options, okay? So the question becomes, well, how do I enroll? All right. You can use the Medicare enrollment portal. It's called PACOS. There are different types of applications. You have an individual enrollment application if you're enrolling as an individual. If you're enrolling as a group, there's a group application. And then if you, let's say you have a company, like a corporation, ABC Chiropractic, PLLC, you enroll ABC Chiropractic PLLC under an 855. You enroll yourself as an individual, and then you link yourself to your group through an 855R. Now, this seems very complicated, but honestly, once you get into the Medicare enrollment portal, it kind of guides you through the whole thing. You would want to get a PACOS login to do that. I'm not even going to go into the DME application right now, because I think this is enough to unpack. But to obtain a PACOS login, you go to the CMS Identity and Access Management System, confirm your login and password. And you may already have one and not realize it, because it is the same login and password you use to access your NPI registry through NPPES. So it could be something as simple as just doing a password reset. And if you do that, then you can get into PACOS. And if you've never applied for an NPI, make sure you sign up for an account through INA and then use the same login and password for INA, NPPS, and PACOS. Now, this is the INA, what this will look like when you log in, okay? What did I do here? Hold on a second. I'm not sure what happened here. Can you see this? Let's see. Let me come back. Okay. Can you all see this? Somebody say yes, if you can, in the chat. Perfect. Thank you.
We
Okay.
can see it.
Okay, great. All right. So this is the INA system to log in. And then let me get to the next screen. So if you have an account but don't know your user ID or password, you can go to the Retrieve Forgotten User ID section, and then just follow the steps to either create an NPI. If you don't have an NPI number and you're brand new, I don't know who's listening to me. You may all have been in practice for a long time, or we may have some brand new doctors who are just newly licensed and you need to get an NPI. So this is what you're going to do to obtain an NPI, and then also to create an account that will allow you access to PACOS and NPPES. All right. Your Medicare Part B administrative contractor for Texas is Novitas Solutions, jurisdiction H. And Novitas also serves our neighboring states, Oklahoma, Louisiana, Arkansas, Mississippi, New Mexico, and Colorado. Now, for Medicare Advantage provider enrollment, if you are in network with a commercial payer that offers Medicare Advantage contracts, you usually don't need to do additional credentialing for the PPO plans. But if you do want to participate in any of the HMO plans, then you would want to check with provider enrollment and see if they have you listed as a participating provider on the HMO plans that are in your service area, okay? Also remember that Medicare Advantage contracts are renewed annually. So sometimes, and what we're finding is that some payers pull out of markets, and they may not offer the contract in your geographic area, and new markets, new lines of business come in every year. So every year it's important to check with Medicare for a list of Medicare Advantage service providers in your area, to make sure that you remain in network with all the different service providers that you want to be in network with, okay? So there are a couple of FAQs that I wanted to go through with you, and then we will go ahead and take our full 15-minute break. But the one question I get a lot is, can I be a PAR provider with Medicare B and be a non-PAR provider with the Medicare Advantage plans? Okay. Now, even if you are out of network with a payer, with a Medicare, let's say you're out of network with Blue Cross, all right? Some Medicare Advantage PPO plans will treat you as a PAR provider if you're PAR with Medicare. Now, the HMO plans usually require separate enrollment, but do be aware that the PPO plans may behave differently, okay? So if you're a PAR provider with Medicare and you're non-PAR with like a commercial payer, it could be that you end up being deemed as a PAR provider, with the Medicare Advantage plans. Also, Medicare private fee-for-service plans, which are rare, can deem you as in-network unless you notify the patient in advance that you don't participate in their plan. So basically, always look at the insurance card for the Medicare Advantage plans, and if it says PFFS, private fee-for-service plan, if you're not in network, you have to let the patient know in advance that you're not in network and they are subject to the out-of-network rates, or if there are no out-of-network benefits. Otherwise, you could bill and then there are no benefits and then you have to write off the whole thing. So just be aware of that as well. Here's another one I get a lot. I'm in network with most Blue Cross Texas plans, but I want to be out of network with the Medicare Advantage plans. Can I do this? All right. Most of the time, you can't pick and choose commercial versus Medicare Advantage contracts. And if you try to do that, disenrolling from a Medicare Advantage contract could actually kick you out of all commercial plans. So always check with the payer on this. Get with a provider enrollment specialist at the payer and ask them this question. Some payers do allow you to opt out of the Medicare Advantage plans, but if they don't, and you say, well, I don't want to be in them, then they'll pull you out of the Medicare Advantage plans, but it'll also kick you out of everything. So just, unfortunately, we've seen that happen on a few occasions, and it's not pretty. So, any questions on this? I don't see any open questions. And I don't see anything in the chat. So it's 10:25. So we will come back at 10:40. And then we'll chuck back on. Okay. Now, when you come back at 10:40, you will have to retype in your name and your license number. Thanks. All right, we are a couple of minutes from getting started again. So if you all want to start putting your name and license number into the chat box to let us know that you're back, I'd appreciate it. Okay, we're going to go ahead and get started again. And this segment is going to be focusing on chiropractic coverage for Medicare and the clinical documentation requirements that you as providers have a responsibility to fulfill in order for you to be compliant with Medicare billing for chiropractic services. So let me get my PowerPoint going. So, one of the things that I like to talk about as far as understanding the rationale and the necessity for documentation is this concept that payers have, and particularly Medicare, Medicaid, and the programs that are under the CMS guidance, is that they pay or state that they will pay for medical services that are deemed to be reasonable and necessary. So, according to Medicare, in order for a medical service, procedure, or supply to be paid by Medicare, the provider or supplier must prove that the services were both reasonable and necessary. So, that begs the question, how in the world do payers define medical necessity? What they do is payers will review the scientific data on specific conditions, and then based on that scientific data, they will create policies based on the data that they have at the time of publication. So medical policies, and there are usually two different types of policies. You have the medical policies that will in general define medical necessity and how to establish medical necessity, and then the documentation requirements that are needed to prove medical necessity. Then you have what are called the reimbursement policies, which generally define how to code and bill for certain procedures. So this would include information on what CPT codes to use, what ICD-10 codes are approved for a certain type of condition, modifiers that may be needed, whether prior authorization is required. So many reimbursement policies will also contain information about documentation and guidance to prove medical necessity. Now, what these policies combined do is define the standard of care for that particular insurance company. Medicare has a slew of policies that are used as guidance to define medical necessity and to help navigate billing and coding for Medicare claims. So the first one that I want to point out to you is the Medicare Benefit Policy Manual, in particular, Chapter 15, which is the chapter on covered medical and other health services. Now, this is the mother policy, okay? It's like the mothership. It's the national policy that governs chiropractic services. Then you have what are called national coverage determination policies, which drill down into certain specialties and that are written on a national level that are to be followed throughout the US. It's not specific to a certain payer or a certain MAC, and a MAC is a Medicare Administrative Contractor. Then you have what is known as the local coverage determination documents and the local coverage articles. Now, these are local to a particular Medicare Administrative Contractor. And what the Medicare Administrative Contractors do is they take national policy, they interpret them, and then they either spit them out as a local policy or they spit them out as an interpretation of the local policy. All right. And it helps provide additional information on how to establish medical necessity, treatment limitations, and documentation requirements for initial and subsequent visits. The LCAs, which are the local coverage articles, deal with the coding and billing guidance. So just like I said in the previous slide, you have the medical policies and the reimbursement policies. Under Medicare, the LCDs are the medical policies, the LCAs are the reimbursement policies. Now, Medicare doesn't always make it easy, as we know. And so in what you can do is you can go to your MAC's website to find your policies, all right? Not all MACs publish LCDs or LCAs, all right? And so in order to find the correct policy, what you do is you go to your MAC's website. This is Novitas Solutions, Medicare Part B, Jurisdiction H, which is for providers in Arkansas, Colorado, Louisiana, Mississippi, New Mexico, Oklahoma, Texas, and Indian Health and Veterans Affairs, right? You can look for the policy through a policy search tool, which is usually at the top of the screen, or they have a comprehensive menu on the left side of the screen, and you would look for the link that says medical policy /LCDs. Now, when you click on that, there is if you go to the fast track, the Novitas gives you a guidance on how to find your policy. So number one would be to look for a national policy. So is there a national policy? Yes or no? Locate the guidelines on the CMS website, view the LCDs, and then locate the guidelines on the Novitas website. So the national coverage determination documents are found on cms.gov. The LCDs are found on Novitas Solutions website. And what happens if there's no medical policy at all? So if there's no medical policy identified, then you have to go back to the national guidance documents, okay? So you would look for medical policy LCD. When I do that, and I look for them every year new policies are either added or removed. And please understand that a MAC does not have to publish an LCD or LCA. They may just say, you know what, the national policy is good enough. And so if you go to your MAC and you don't find an LCD or LCA, then you look for the national policies, okay? Now, some MAC's policies you'll find are more robust than others. They have better explanations about things. You can use other MAC's policies when conducting appeals and redeterminations of unpaid claims, but remember that there's no guarantee that your local MAC will honor the LCD or LCA of another MAC. So in cases like that, you would want to, again, make sure that you're following the guidance and the policies on the national level in order to protect you against recoupments on audits and things like that. So in general, you want to use the policy and guideline for your MAC. Always look for the most recent version. If no LCD exists, refer to the National Policy for Documentation and Treatment Guidelines. And if no national policy exists, which happens, then you refer to what's called the reasonable and necessary guidelines set forth by Medicare or explore other MACs LCDs. So if the MAC does not have an LCD, what other coding and documentation compliance tools does CMS provide us? FYI, if you go to Novitas JH and you look for an LCD, you will not find one. In that case, because Novitas, our MAC in Texas, does not have a published LCD for chiropractic services, we have to go back to the CMS National Coverage Policy, which is current as of January 1st, 2026. And we want to look for Chapter 15, Sections 30.5, Chiropractor Services, Section 240, Chiropractic Services General, 240.1, Coverage of Chiropractic Services, 241.1, Manual Manipulation, 241.2, Demonstrating a subluxation by either X-ray or physical exam, 241.1.3, medical necessity, 240.1.4, how to locate a subluxation, and 240.1.5, which outlines treatment parameters. Now, we're going to unpack all of this in the next couple of hours, and I'm going to show you screenshots of these policies. We'll discuss them. I do want you please engage in questions and answers. If you have any questions about this, please go ahead, start typing them in, and then when we come to an acceptable stopping point, I'll answer your questions about this, okay? There is also a Medicare Claims Processing Manual, which is publication 100-04. In that publication, in Chapter 12, there is a section on chiropractic services, and then in Chapter 30, there is also a section on financial liabilities. Now, one of the other things that you can do on Novitas is you can look for the specialty services. So in the menu on the left side, you'll see that there is a section called specialties/services, and there is a link for chiropractors. This is very valuable because what this does is that it will drive you to all the links that you need to be able to accurately and compliantly bill for chiropractic services. The articles within that section are articles on chiropractic services FAQs, which we'll unpack in this class, common reasons for claims rejections, the LCA, which is the billing and coding article for chiropractic services, the Medicare documentation job aid, which we will also discuss at length today, the publication SE 1601, which is Medicare coverage for chiropractic services, medical record documentation requirements for initial and subsequent visits. That is a companion document to the job aid. All right, it actually contains the same information, but the job aid itself is actually a templated document that you can use for your notes and for your documentation templates in your EMR. SE 1602, which is how to properly use the AT modifier for chiropractic billing, and then SE 1603, which is another document that provides you with all of these links, okay? You can also get directly in the resources to the publication 100-2, which is the Benefit Policy Manual, Chapter 15, Sections 30.5 and 240 that we just discussed, and publication 100-04, which is the Claims Processing Manual, Chapter 12, Section 220. So you'll find all of these in one place. You don't have to go hunt and peck for them. go to Novitas, click on specialties/services, click on the chiropractic specialty, and then you'll find all of your resources in one place, okay? Let's talk about what Medicare defines as reasonable and necessary guidelines. So Medicare states, in the absence of an LCD or a national policy, the reasonable and necessary guidelines apply. Now, the reasonable and necessary guidelines are found in Section 1862A1A of the Social Security Act. So this is actually written into federal law. It states that no payment may be made under Part A or Part B for any expenses incurred for items or services not reasonable and necessary for the diagnosis or treatment or injury, or to treatment of illness or injury, or to improve the functioning of a malformed body member, okay? The MAC will determine by law if an item or service is reasonable and necessary under the Act, as long as the service is, number one, safe and effective. We know that that is the case in chiropractic, not experimental or investigational. We know that that is also the case for chiropractic services. It's not considered experimental or investigational, and appropriate, including the duration and frequency in terms of whether the service is furnished in accordance with acceptable standards of medical practice. This is where your policies come in. So the duration and frequency is defined by the policy for the diagnosis of the condition, okay? Furnished in a setting appropriate to the beneficiary's medical needs and conditions. So typically either in an office setting or in the patient's home, ordered and furnished by qualified personnel, such as doctors of chiropractic, and one that meets but does not exceed the beneficiary's medical need. Okay, so this is where we get into, when do we shut the faucet off of active care and move them into maintenance care, because maintenance care is not covered. And if we're billing for care that's maintenance, we are exceeding the beneficiary's medical need. So this is part of those reasonable and necessary guidelines. It also says in the law that for any service reported to Medicare, it's expected that the documentation clearly demonstrates that the service meets all of the above criteria. All documentation must be maintained in the patient's medical record and be available to the contractor upon request. So you're not having to send your notes in with your claims, at least not yet. That technology is being worked on, and that may actually happen in the next few years, where you're just going to submit your notes every time you submit a claim. But that hasn't happened yet. But you do have to make sure that the notes are complete and completely done at the time that the claim is submitted. All right. And you have to make sure that if the contractor, such as Novitas, asks you for medical records, you provide those medical records to them upon request. So let's start by looking at the Medicare Benefit Policy Manual that governs chiropractic services. And we are going to look at Chapter 15. And we're going to look at sections 30.5 and 240.1. So again, don't kill the messenger, guys. I'm just spouting what the policy says. And this is literally copied and pasted directly from the document, okay? So basically, and what I've done is I've highlighted or underlined some of the highlighted talking points, okay? First of all, you have to be licensed, legally licensed to furnish services. That goes without saying. Medicare's coverage of chiropractic services is extremely narrow and extremely limited. And it states very clearly that coverage extends only to treatment by means of manual manipulation of the spine to correct a subluxation. All other services furnished or ordered by doctors of chiropractic are not covered. And remember, we are talking about original Medicare now. This does not apply to Medicare Advantage plans in which there are extended benefits. So if there are extended benefits in Medicare Advantage, then they have their own policy guidelines that govern this. So we are looking at Medicare Part B, and we're looking at Medicare Advantage plans that have standard Medicare benefits. So they don't cover anything other than what Medicare covers. And so all other services furnished or ordered by chiropractors are not covered. Now, ordered is important because one of the services that you may need to perform on a patient is an x-ray. All right. And if you are the ordering provider of that x-ray, let's say you send the patient out for an x-ray to a radiology center, or you send them to the hospital to get an x-ray done, or you send them to another chiropractor that maybe has x-ray. First of all, x-rays themselves aren't covered, but if you order an x-ray and you order the patient to go to a medical facility in which that x-ray may be covered because it's being performed by a radiologist who it's being read by a radiologist who's an MD, if you're listed as the ordering provider, Medicare will deny that. All right. So you may not even be the ordering provider under those types of circumstances. So the question is, if all that is covered is the correction of a subluxation, how do we document a subluxation? All right. Under Section 240.1.2, Medicare states that subluxation can be demonstrated in one of two ways, either X-ray or physical exam, neither of which is covered by Medicare when ordered or furnished by a chiropractor. All right. And so you have to do one of these. You have to either take an X-ray or do a physical exam, but you have to make the patients understand that Medicare is not going to pay for it if it is performed or ordered by yourself. And we will discuss next week on how to make those notifications to the patients using ABN forms or Notice of Exclusion of Medicare benefit forms. So the first one that we're going to look at is, we're going to kind of do it backwards. We're going to look at exam first because this is the most common way that a chiropractor will prove subluxation. X-ray, not as much. Now, it used to be up until the year 2000 that X-ray was required, but they took that requirement out in 2000. So for the last 25 years, it has not been required, but can be used as criteria to demonstrate a subluxation. So let's look at physical exams. So the physical exam that you have to perform to demonstrate a subluxation and prove medical necessity is called a PART exam, P-A-R-T. And it is an acronym that is an evaluation of the musculoskeletal or nervous system to identify pain and tenderness, evaluated in terms of location, quality, intensity, asymmetry or misalignment, identified on a sectional or segmental level, range of motion abnormalities like changes in active, passive, and accessory joint movements, resulting in an increase or decrease of sectional or segmental mobility, so hypermobility or restricted mobility, and tissue tone changes in the characteristics of contiguous or associated soft tissues, including skin, fascia, muscle, ligament. This is where you're going to be documenting muscle spasms and changes in the characteristics of your skin, fascia, and ligaments. All right. This is known as a PART exam. In order to demonstrate subluxation based on physical exam, 2 of these 4 criteria are required to have been met, one of which of the 2 has to be A or R, asymmetry or range of motion. So If all you document is pain and muscle spasm, that's P and T, that does not cut the proof for medical necessity. You can document pain and asymmetry, pain and range of motion abnormality. You can do all four, of course, but if you're only doing two, one can be pain or one can be tissue tone changes, but one of the other two has to be asymmetry or range of motion. You can't have pain and tissue tone changes as your two. That is not going to prove medical necessity according to Medicare standards. Now, this is just an example, again, a visual example of what you might see on a part exam. Now, remember that evaluating pain is both subjective and objective. So you are going to ask the patient about their pain levels. You'll ask them, where does it hurt? What is the nature of the pain? Is it aching, burning, stabbing, spasms, numbness, pins and needles? Is it a throbbing pain? Where's the location of that pain? All right. And then you would have them identify on a pain scale if the pain is at a level 0, which is no pain at all the way to excruciating, which is the patient is literally in tears, can't walk, can't move, and is asking you for serious drugs to get rid of their pain, right? So it's a subjective pain assessment that you must confirm with your objective exam and your objective findings, okay? So this is the P part of the part exam. The next part of the exam is going to be the A and the R, where you're going to document through either some type of a visual type of document. You can document it based on palpation. If you can find asymmetry within the vertebra, that would be your A section. And where you would list what segments of the spine, what vertebral segments have asymmetry, and then range of motion. And typically the range of motion studies that you're going to do for a Medicare patient are going to be spinal range of motion, not extremities, because Medicare doesn't cover extremities. They only cover segmental dysfunction of the spine. All right. So the 5 levels of the spine is where you're going to do any type of range of motion, flexion extension studies, rotation studies in the cervical and in the lumbar area, okay? And then you have the T, which is the tissue abnormalities, where if you are going to identify, you have the patient down on the table and you identify areas of spasm or trigger points, you would identify those in the different areas that are contiguous areas to the spine. Okay. Then on top of that, you would do your routine ortho and neuro exam. Okay. And again, this is just a visual. These are this isn't all the exams, the exam tests that you can do. These are some of them. You may have your own favorite tests that you would want to add. I'm not a doctor, so I'll just tell you, if you ask me what test should I use for this, I'm going to tell you, I don't know, ask a chiropractor. So I don't know, but those are some of the relevant orthopedic and neurological tests that you would do to confirm the subjective complaints that the patient has. So this is what would make up your part exam. And again, remember, one of the 2 criteria to prove subluxation is going to be to prove either asymmetry or range of motion restriction or hypermobility in range of motion. Okay, it can't just be pain and tenderness or pain and muscle spasm. In 240.1.2, an X-ray can also be used to document subluxation. Now, Medicare states that the X-ray has to be taken at a time reasonably proximate to the initiation of a course of treatment. Unless more specific X-ray evidence is warranted, an X-ray is considered reasonably proximate if it was taken no more than 12 months prior to, and I love this one, or 3 months following the initiation of a course of chiropractic treatment. So essentially, what Medicare is saying is if you want to use X-ray to prove a subluxation, you don't have to do it for 3 months. Well, that's kind of crazy. To me, that's malpractice. If you just start treating a patient, you didn't do an exam, you're wanting to use X-ray to prove a subluxation, but you're not going to take an X-ray for 3 months. I would not recommend that personally. Okay. I would strike out that 3 months following the initiation of a course of treatment, unless you want to prove progress. Okay. Then yeah, if you want to take an X-ray, when the patient comes in and then take another X-ray in 3 months, I know some of you may be listening and you do certain chiropractic procedures and types of chiropractic work that requires you to re-X-ray patients. And I think like Atlas orthogonists will do that, will re-X-ray patients to show that they're improving the curvature of the neck. And so, if that's what you do it, obviously, right? But I would not wait 3 months to take your first X-rays of a patient if you are going to use X-ray as the criteria to prove a subluxation on a Medicare patient. Okay, now Medicare does state that an older X-ray can be accepted provided the beneficiary's health record indicates that the condition that they have has existed longer than 12 months, and there's a reasonable basis for concluding that the condition is permanent. So, for example, if the patient has deterioration, spinal, DDD or DJD, that would imply that is a permanent condition, right? In that case, a previous X-ray or CT or MRI is acceptable if a subluxation of the spine is demonstrated on that particular image. Okay, so these are how you would establish medical necessity for a part exam. Now, what are the conditions or types of conditions, types of subluxations that support active treatment? And there are two. And this is where we get into a lot of old wives' tales with chiropractic, okay? I hear doctors tell me all the time, well, Medicare doesn't cover chronic conditions. Medicare doesn't cover this. Medicare only pays for 12 visits. And we're gonna bust all those myths in this class, okay? So the first condition that Medicare publishes that would support active treatment is an acute subluxation. Medicare defines this as a new injury identified by X-ray or physical exam as specified above, meaning above is what we just discussed, okay? The result of chiropractic manipulation for an acute subluxation is expected to be an improvement in or arrest of progression of the patient's condition, okay? That's your acute subluxation. The other that Medicare supports for active treatment is a chronic subluxation. And this one is where many of your patients actually are. Many of your patients, Medicare patients, are going to be chronic patients. And Medicare states that a patient's condition is considered chronic when it's not expected to significantly improve or be resolved with further treatment, as is the case with an acute condition, but where continued therapy can be expected to result in some functional improvement. Now, that word functional improvement, and I'm going to tell you this, in the Medicare document, I've counted it, the word functional improvement in the policy is used 76 times. Pain is used about 14. And this is where I think chiropractors get it wrong. Instead of documenting improvement of function, they keep documenting pain levels. And once the patient's pain levels are down to a manageable level and they don't change, then there's no reason to keep treating them under active treatment, and they need to be moved into maintenance. But if you have a patient that has significant degeneration of the spine, right? Or you have a patient that has comorbidities, like they're severely obese, all right, and or they do some type of work or some type of activity that continues to create subluxations that are resulting in functional deficits. You have to document those functional deficits and document how you are affecting improvement in that function in your documentation. Okay. Medicare states that once the clinical status has remained stable for a given condition without expectation of objective, not subjective, but objective clinical improvements, further manipulative treatment is considered maintenance therapy and is not covered. So let's talk about the treatment parameters. Again, I hear so many different things. Like some doctors say, well, I give my patients their 12 visits and then I move them to maintenance. Or, I've heard that Medicare will start auditing you after 6 visits. So I only give them 6 visits and then I push them into maintenance, right? And so Medicare doesn't say any of that. Those are complete old wives' tales. And here's what Medicare says. The chiropractor should be afforded the opportunity to effect improvement or arrest or retard deterioration in such condition within a reasonable and generally predictable period of time. Okay. Acute subluxation problems may require as many as 3 months of treatment, but some require very little treatment. So Medicare is leaving the door wide open for you. Okay. In the first several days, treatment may be quite frequent. So you know what, if you are doing the treatment standard of you see patients like the first week you see them, maybe you see them daily, then week 2 you see them 3 times a week, week 3 you see them 3 times a week, you reassess, you drop them down to 2 times a week for a few weeks and then once a week. That's what Medicare says you should be doing. Okay, treatment may be quite frequent, but decreasing in frequency with time or as improvement is obtained. Now, they do define chronic spinal joint conditions, all right? And they state chronic spinal joint conditions implies the condition has existed for a longer period of time and that in all probability, the involved joints have already set and fibrotic tissue has developed. This condition may require a longer treatment time than 3 months, but not with higher frequency. So this is those patients that, you know what, they come back every 2 weeks, every 3 weeks, once a month, once every 6 weeks. And if you can prove on those patients that they're not just coming back for a manipulative aspirin, meaning that, they have a little bit of pain, they got a little bit of stiffness and soreness, but it's not really affecting them functionally. All right. They're still on maintenance, even though they may have some pain. But if you've got a patient that is like, has severe degenerative conditions in their spine, and they're, in their 90s or whatever, and they are living at home and they're living by themselves and they don't have, any help or any support, and they're unable to get around and care for themselves because of their condition, and they have to come back every 2 weeks for treatment so that they can walk and they can cook and they can dress themselves and they can bathe themselves. That's function, all right? Your activities of daily living. You can keep treating them as an active patient, but you have to document what it is they are unable to functionally do at the time they come back to see you, and then provide a documentation on how you have been able to restore the patient to their previous functional levels. All right. So this is the big difference between an acute treatment patient and a chronic patient. And again, you can treat your chronic patients and bill Medicare for them, but your burden of documentation changes with the different type of subluxation that you're treating. Now, Medicare states this is in section 30.5 under maintenance therapy. It says chiropractic maintenance therapy is not considered to be medically reasonable or necessary and therefore not payable. For me, and if you've ever taken my class, you'll hear me say this. To me, this is kind of the saddest sentence that Medicare has ever put out. Maintenance therapy is defined as a treatment plan that seeks to prevent disease, promote health, and prolong and enhance the quality of life, or therapy that is performed to maintain or prevent deterioration of a chronic condition. Okay, so as somebody who, if I was a chiropractor, that would hurt my heart. Okay, and it does, and it hurts me because I am. I'm not a chiropractor, but I am a chiropractic patient. I've been a chiropractic fan for over 40 years, and this is what we do. This is what chiropractors do. You seek to prevent disease, promote health, and prolong and enhance the quality of life. And guess what? What Medicare is doing is telling you if that's what you want to do, then guess what? Your patients can pay cash for that, which is great. So in a way, because then what that does is that allows you the freedom to say, as a chiropractor, to the maintenance patient, I want to help you get through this episode in which your function is deteriorated and which you have, or in this episode in which you have significant pain. But that's not what we're about, okay? Medicare will pay for this part of it, but that's not what we're about. What we're about is preventing you from having further deterioration of this condition. We want to promote good health and prolong and enhance the quality of your life. So, and unfortunately, Medicare is very clear that they don't pay for that. So what we want to do is we want to get you through this episode, and then we want to get you into maintenance so that you don't have to keep coming back with these types of continued deterioration of your function and of your spine. All right. That's my soapbox, guys. And sometimes I think that we in the chiropractic profession, we look at this as a negative, but I personally look at it as a positive because it frees you up to do what you do and do what you do best and not have to worry about insurance. Okay. So if you are a pain management doc and that's all you do, and you don't, you basically just kind of release patients and let them go whenever, come back whenever they're hurting, quote unquote, then you're losing out on the richness of what you can be doing with your patients. And frankly, just taking off my compliance hat and putting on my practice management hat, you're losing the potential for the new patients to become great lifetime patients of yours. Okay, so, but Medicare is very clear. They don't cover maintenance. Now, some Medicare Advantage plans actually do, and we'll talk about that next week when we get into billing for Medicare Advantage. So, there is a document called Documentation FAQs that Medicare has published. And so I thought it would be a really good idea to go through these FAQs and look at them one by one, because I think a lot of these would be, in your mind, Q&A questions. So I'd like to go through the FAQs, and then if you still have questions after the FAQs are reviewed, then you can always type them into the Q&A, okay? All right, so the first one is, what are the differences in documentation requirements for an acute problem versus a chronic problem? Medicare states documentation for an acute problem should indicate in the documentation that the expectation that the treatment results in the improvement in or arrest of progression of the patient's condition. Some statement in your documentation should should address that. Okay, documentation for a chronic problem should indicate that the expectation that stabilization or continued treatment results in some functional improvement. So this is where you need to establish what are the functional deficits that the patient is experiencing, and within your documentation, make a statement that says, we expect that after this this course of treatment, whether it's 1 visit, 2, 3, 4 visits, we're going to get the patient back to their normal levels of function. Okay, and that function is being able to dress themselves, being able to tie their shoes, being able to play golf. You know, it could be a recreational function, it could be a personal function, but you want to make sure that you're documenting function if you are going to treat patients actively for chronic conditions. Number 2, is it acceptable for a chiropractor to use his or her own abbreviations in the medical record, i.e. abbreviations other than those widely used by chiropractors? Abbreviations, and Medicare says abbreviations commonly used with any specialty are acceptable. However, if your patient's medical records contain abbreviations not commonly used and you receive a request for records, please provide a key to the abbreviations. Submit the key or the legend with the medical records to assist in the review. 3, 4, and 5. In chiropractic documentation, can regions identified in the exam component be inferred as regions adjusted? And the answer is clearly no. When you are documenting, and we'll be talking about this when we go through the initial and subsequent visit documentation requirements, the documentation must state the specific regions adjusted. In chiropractic documentation, can we use pain levels to support acute or chronic category subluxation? And the answer is no. You must clearly state the acute or chronic category of subluxation in the patient's medical record. So it's not just about pain levels. You need to identify, pain levels are important, but you want to identify misalignment, you want to identify range of motion abnormalities, you want to identify tissue changes, and so on and so forth. In chiropractic documentation, must we document the treatment effectiveness for each billed date of service? And the answer is yes. The documentation must indicate an evaluation of the effectiveness of the treatment provided for subsequent visits. So some statement for each visit saying patient's response to treatment has been positive, and we anticipate that the plan of care as outlined on such and such a date is going to be fulfilled. This treatment has been effective and patients' ADLs are improving, but still need a little bit more work, okay? So the documentation must always, for each date of service, an evaluation of the effectiveness of the treatment provided for subsequent visits. Number 6, I submitted x-ray reports with subsequent visits, but they denied as out of date. Why? And again, this just goes back to the rule that x-rays have to be reasonably proximate to the initiation of course of treatment. They give you the 12 months prior to or 3 months after, and then the chronic subluxation, the older x-ray may be accepted, okay? It also states that the provider can use a previous CT or MRI for the spine in lieu of an x-ray when it demonstrates a subluxation. And the time frame is applicable, the same time frame is applicable for MRI and CT scans. Number 7, I perform a thorough exam of my patient with the initial chiropractic visit and then refer to the initial exam findings in my subsequent visit notes. Is this acceptable? And Medicare says yes, as long as, and again, remember that they're talking about if you're audited, right? As long as you submit the initial exam findings with each billed subsequent visit when responding to medical records requested by us or the CERT program, the Comprehensive Error Rate Testing Program. Number 2, do Novitas Solutions medical review nurses deny chiropractic services based on medical necessity? Now, This is interesting because this takes you into the inner workings of audits. So what Novitas is telling us is that when your office receives a request for records to substantiate your services, it first goes to a nurse reviewer. Now, what the nurse reviewers do is they review the documentation to verify that you've met all the elements of a good SOAP note. Okay, now they're not going to evaluate medical necessity. They're just going to look at your note. And did you address all of the elements of the note? Was the note signed? Was the note timely? Did the note include reference to your part exam? Did the note include your treatment and the expectation of recovery? Did the case include a treatment plan? We're going to go through all of this, but that's what they're looking for. Okay, they're just looking for the completeness of the documentation. All right. Now, if you met the documentation requirements, the nurse reviewers then send the documentation to a chiropractic consultant to determine the medical necessity for the services. So now they're going to look at your notes and whether your diagnosis codes and your notes, your objective findings and assessments prove medical necessity for the services. If you did not meet the documentation requirements, not medical necessity, the nurse reviewers will deny the service. They won't even send it forward to medical necessity based on the lack of documentation. Okay, so that's kind of how these audits work. They go to a nurse reviewer first. And then if the nurse reviewer determines that your documentation is complete and good, then they send it to a chiropractic consultant for a peer review on the medical necessity of the services. Number 9, what is the AT modifier and when do we report it? Modifier AT, and we're going to go into, again, more detail on this next week when we get into the billing and coding section, defines the difference between active treatment and maintenance treatment. The AT modifier is required under Medicare billing to receive reimbursement for CPT codes 98940, 98941, and 98942. For Medicare purposes, the AT modifier is used only when chiropractors bill for active corrective treatment, acute, and chronic care. All right. Every chiropractic claim for these 3 codes should include the AT modifier if active and corrective treatment is being performed. Claims that do not contain the modifier AT will deny, and it tells you very specifically, do not use modifier AT for maintenance therapy. And then the last one is, where can I find diagnosis codes for chiropractic services? For chiropractic services to be covered, they must be reasonable and necessary and meet CMS guidelines. You can find diagnosis coding guidelines in our local coverage article, A58345, Billing and Coding for Chiropractic Services. And we will be going through this as well in our billing and coding section next week. All right. Very quickly, are there any questions before we get into the aids that you have from Medicare for documentation compliance? Let me look at the chat box and see if there's anything in there. I don't see anything in the Q&A. I don't see anything in the chat box. All right. We'll continue to move forward. We got about an hour left, and this should take us right to the end of this section. All right, so the first document that I want to point out is the MLN Matters. MLN Matters, MLN stands for the Medicare Learning Network. And if you go to cms.gov, there's a whole subsection called the Medicare Learning Network. And Medicare publishes these articles, magazettes, I call them. They're not magazines. They're like little 2-3 page articles, and of various, types of topics. All right. There's articles on provider enrollment, on how to use PACOS. There's articles on, other types of medical specialties. And so this is a kind of a library of articles that will help navigate your documentation requirements. There are a couple that are really important for chiropractic, the SE 1601 and the SE 1602. The SE 1601 is entitled Medicare Coverage for Chiropractic Services, Medical Record Documentation Requirements for Initial and Subsequent Visits. So, again, we're copying and pasting some of the highlights of this document, all right? If you want the full document, you can go to Novitas Solutions to their homepage. Down at and I had this on some previous slides. Down on the left side, there's a menu. At the bottom of the menu, there's one that says specialties. Click on that. Click on chiropractor, and then the SE 1601 link will be right in there. So you'll have 1601, 1602, 1603, and all of the others that we're going to be looking at here today. Okay. So why did they write 1601? And 1601 was written in 2019 as a response to a CERT audit, which stands for Comprehensive Error Rate Testing, that measures improper payments in the Medicare fee-for-service model. The CERT audit in 2018 for chiropractors reported a 41% error rate on claims for chiropractic services. Most of those errors were due to insufficient documentation, all right? So they never made it past the nurse reviewers or other documentation errors. Medicare limits coverage of chiropractic services to treatments by manual manipulation to correct subluxation, okay? And it basically goes through the kind of the rules of chapter 15, section 30.5, okay? It does address, for those of you who use hand instruments like Activator or Pro Adjuster, the policy does state that the DC may use manual devices, those that are handheld with the thrust of the force of the device being controlled manually in performing manual manipulation of the spine. I do get that question from time to time. So yes, your Pro Adjuster is acceptable. Yes, your Activator is acceptable, and other similar devices in which you manually control the thrust with the device, okay? Medicare makes no additional payment for use of the devices, nor does Medicare recognize an extra charge. So the documentation requirements come from the different sections of the Social Security Act, under the reasonable and necessary provisions, and under the initial and subsequent visit provisions that meet specific documentation requirements. And it actually points you to the sections of the policy in which you can find the more robust language. So this is now getting into your documentation templates, okay? And what I want you to do is, as we're going through these bullet points, I want you to be in your mind doing an internal risk analysis or risk assessment of your own documentation, okay? Ask yourself the question, as we go through these different bullet points, are you documenting this, okay? And if not, or the other question you can ask is, are these bullet points incorporated into my documentation templates in my EMR? If you're using an EMR, or, electronic medical record, has your template been built to accommodate these bullet points? Because if they're not, and you're missing them out, then, you can have a beautiful EMR system, but the bottom line is that EMR system isn't going to be worth anything if it's not capturing the data that needs to be captured based on the documentation requirements. So in your mind, let's start looking at this personally as a risk analysis of your own documentation. And at the end of this, give yourself an honest grade of what your documentation is as opposed to what it should be. Okay. And if if you're doing a great job, but maybe you're missing one or two things, then Make note of that and make sure you make those corrections in moving forward with your documentation, okay? So this is what Medicare specifies the documentation requirements are for your initial visit, okay? Whether the requirements apply for initial visits, whether the subluxation is demonstrated by x-ray or by physical exam. Number one, a history. So a good patient history. The history in the provider's record should include the following: a chief complaint. Why is the patient here? Including the symptoms that are causing the patient to seek treatment. All right, a statement of why is the patient coming in today? All right. And by the way, the chief complaint should be listed every time you see the patient. That's one of the big dings that I see. I do a lot of independent audits of chiropractors documentation. Okay. So a chiropractor will call me and say, Lisa, can you look at my notes and tell me where I'm missing the boat? You know, and so I will do an audit. And I can't tell you how many times the chief complaint is missing. It's almost like when you get to the subsequent visits, you just kind of launch into, you know, the patient felt this and the patient did that, and we did this treatment and everything is good, and you forgot to list the chief complaint, like the reason for the visit, okay? Auditors love that because they'll deny the whole visit if you don't have a chief complaint. So the history should include the chief complaint, a family history if relevant, okay? A family history is going to be relevant in cases where you may be treating patients for a musculoskeletal condition that is congenital, all right? Past medical history, general health, prior illnesses, injuries, hospitalizations, medications, surgeries, etc. That should always be in your history. So think about your intake forms, all right? Do your intake forms provide the fulfillment of these bullet points? Number two, present illness. Description of the present illness, including mechanism of trauma. What happened? Did you hurt yourself? Were you out gardening? Was the patient out gardening and they were bent over, you know, for 4 hours, and when they got up, their low back was killing them and they couldn't move and they, you know, they had no range of motion? What was the, you know, did they fall off a horse? Was it just, you know, they work on a computer 8 hours a day, and over time their neck and shoulders really began to experience significant pain and spasm, and they have a, you know, forward tilt to their neck? Mechanism of trauma, quality and character of symptoms and problem. So again, this is in the patient's word. Okay, so remember that the history and the present illness is the description in the patient's words, but they need to be addressed. So if the patient isn't addressing him, then you need to document that in your, when you're doing your consultation, ask them those questions if they haven't already indicated that in their intake. Quality and character of symptoms. Where, you know, where does it hurt? What kind of pain is it? You know, throbbing, stabbing, dull, achy. The intensity of the pain, onset, duration. When did it happen? How long has it been going on? How frequently does this pain or this problem occur? Where's the location? Does the pain radiate? Aggravating or relieving factors. What makes it worse? What makes it better? All right. Prior interventions. What have you done before coming to see me to ameliorate these symptoms? Okay. Have you been on any medications? Do you have any secondary complaints as a result of your symptoms? You know, yes, I have severe neck pain that's causing me headaches. That's your secondary complaint. Symptoms that are causing the patient to seek treatment. So for today, tell me what is going on that has brought you in to see me. Okay. Now remember that any symptoms that the patients are experiencing have to be related then back to the subluxation that the doctor of chiropractic cites. A statement on a claim that there is pain is insufficient. Describe the location of the pain and whether the vertebrae listed can produce pain in that area. Physical exam. Now, again, this goes back to the the part exam. So this is how the part exam is described. You would, if you're going to do a part exam, you demonstrate the subluxation. Again, two of the following four criteria have to be asymmetry, misalignment, or range of motion. And you need to document the criteria within each of these, within each of these bullet points, right? So the patient's perception of pain, okay. And then pain or tenderness findings. So you have the subjective, which is the patient's perception of pain. Where does it hurt? What is the nature of the pain, location, quality, and intensity? Then the pain and tenderness findings are your findings. The objective findings may be identified through one or more of the following. So you document observation, percussion, palpation, provocation, and so forth. Furthermore, pain intensity may be assessed using one or more of the following: the VAS, the visual analog scale, algometers, pain questionnaires, and so forth. Asymmetry can be identified on a sectional or segmental level, again, for you through one or more of the following: observations such as posture heat analysis, static palpation for misalignment of vertebral segments, and or diagnostic imaging. Your range of motion you need to document changes in active, passive, and accessory joint movements. These may be identified through one or more of the following: motion palpation, observation, stress diagnostic imaging, range of motion, and or other measurements. So again, if you're going to use range of motion as one of your criteria to prove a subluxation, what did you do to prove restricted range of motion or hypermobility in a certain segment of the spine? And then tissue and tone changes may be identified through one or more of the following procedures: observation. Now, observation in all of them, right? So you can observe, patient, pain and tenderness, patient grimaces or cries out when they move, when they turn their neck to the right or to the left. Observation, palpation, use of instrumentation, and or test of length and or strength. So strength tests as well would show tissue tone changes and temperature abnormalities. Number 4, and again, this is all under the initial visit, okay? Number 4, diagnosis. The primary diagnosis must be subluxation. Now, when we go into the coding section, it shows us here what the subluxation ICD-10 codes are: M99.0, 1, 2, 3, 4, or 5. Okay. And those are the only diagnosis codes. Now, in Novitas, they do allow you to use something called the subluxation complex codes, which are the M99.11, 12, 13, 14, and 15. We will get into the difference between the subluxation and subluxation complex and the description of the subluxation complex, but I will tell you 98% of chiropractors use these subluxation ICD-10 codes, the 0, 1 through 0, 5, as the primary diagnosis for Medicare. Now, I do want to point out that these are pretty indigenous to Medicare and Medicare Advantage as primary diagnosis codes. I do know that many chiropractors use these as primary diagnosis codes for commercial payers. And I'm not saying that's wrong, especially if you're a subluxation-based provider. So if you're a straight chiropractor and the subluxation is the primary condition that you are treating, then yes, you use these as your primary. But if you're more on the functional side, or if you do a lot of PT, or you do extended treatment for other types of conditions, the subluxation codes on the commercial side do not have to be the primary diagnosis. It is only required as a primary diagnosis for Medicare, okay? And so under this SE 1601 document, they give you how to document your subluxations. You can document them by the name of the vertebra, like occiput, cervical, atlas axis, dorsal, thoracic, lumbar, iliac, RL, SI, okay, and then sacrum and coccyx. And then you can use the acronyms, right? Like C1 through C7, D1 through D12 dorsal, T1 through T12 is the most common of the thoracic, L1, L5, I, SI, S, SE. And so you can document them a number of different ways as far as proving the subluxation. You don't necessarily have to use the actual vertebral area. You can just say thoracic, but when you are adjusting the patient, you have to note which vertebra you adjusted, right? I adjusted T1 through T6 and L4 and 5 and C1 through C5, but that is in your subsequent treatment. Now, if you treat patients on the first day, you're going to have to note that in your treatment note, but for the initial exam, when you are identifying the subluxation, this is the acceptable terminology that you would use and the associated diagnosis codes for those terms. Now, there's some common examples of acceptable descriptive terms for the nature of the subluxation: off-centered, misaligned, malpositioned, abnormal spacing, incomplete dislocation, rotation, listhesis. Again, whatever you are comfortable with, you would use, but make sure that these are acceptable descriptive terms. You can use other terms if they are understood clearly to refer to bone or joint space or position or motion changes of vertebral elements. They are acceptable, okay? And so you can list the exact bones of the subluxation, for example, C5, C6, and the area could be suffice if it implies only certain bones, such as occipital atlantal, lumbosacral, L5 and S1, sacroiliac, sacrum and ilium, etc. Now, as of January 1st, 2000, again, and this is, repeated from some other slides, but this is part of SE 1601, does not require X-ray to demonstrate subluxation, and then it gives you the parameters for demonstrating that X-ray. All right, the next part of the initial exam requirements is the treatment plan. And again, as somebody who has audited many chiropractic records, this is probably the biggest area of deficiency in your chiropractic documentation. All right. Many chiropractors that I have worked with over the years, and guys, I've literally done hundreds of these. Okay. They are missing a treatment plan, a written treatment plan. And initially, so the treatment plan should include the following: recommended level of care, which is duration and frequency of visits. Okay, we are recommending a trial of chiropractic care of 4 weeks. And in the first week, we recommend the patient have daily visits. Week 2 and week 3, we recommend 3 times a week. Week 4, recommend twice a week with reevaluation at the end of the 4th week. Specific treatment goals, both long-term and short-term. And your treatment goals are anything like we're going to get our first treatment goal is to get the patient out of pain. Second treatment goal is to stabilize the subluxations. Third treatment goal is to improve functional performance in the following ADLs, right? And then objective measures. What objective measures are you going to use to evaluate treatment effectiveness? Now, we're going to talk about objective measures here in just a little bit through the use of OATs, which are outcome assessment tools. And we'll get into that a little bit more. But these are the elements, the bullet points that you would want to include in your treatment plan. All right. You would then want to document the date of the initial treatment. Okay. And you would want to validate all the information on the face of the claim, including the patient's reported diagnosis, physician work, and modifiers. So what they're saying there is that your documentation should be an exact mirror of the claim, right? If something is on the claim that's not present in your documentation, you have an invalid claim or you have an invalid document, but they're both invalid at that point, okay? So everything should match. You know, when you look at your document and you look at your claim and you put them face to face, they should be an exact mirror of each other, okay? All right, so you can see that the initial visit is really the document and the documentation that sets up the rest of the plan of care. Now, believe it or not, the documentation requirements for subsequent visits is very, very minimal compared to visit one. If you guys can get visit one down and you can really take your time to fulfill the documentation requirements of visit one, subsequent visits become much easier to document, okay? So this is it. 3 elements in subsequent visits, right? The following documentation requirements apply whether the subluxation is demonstrated by x-ray or physical exam. Number 1, history. So review of chief complaint. Why is the patient here? Document any changes since the last visit. Patient's pain levels have gone down, discussed patients' activities of daily living. They've reported now that they can actually bend down and tie their shoes where they couldn't at the last visit. A system review, if relevant, doing another system review. Physical exam. And again, physical exam doesn't mean that you have to sit down and do an exam while you have the patient down on the table. You do what you do. You palpate, right? You observe, examine the area of the spine that is involved in the diagnosis that you reported, right? And during that period of time, notate any assessment of changes in the patient since the last visit, objectively, right? So under the history, remember that number 1, the history is the patient's reporting to you, right? What are we here for today? Oh, I'm just here for, my follow-up visit, okay? For my neck problem. So that's the chief complaint, follow-up visit 2 of 8 for subluxation of C, cervical spine, subluxations of cervical spine and lumbar spine, okay? Changes since last visit, you ask the patient, anything changed since the last visit? The patient may say yes or no. But when you ask them for changes, always ask them for functional changes, okay? Look at and remember what they were not able to do when they first came in, and then ask them about that. Has there been any improvement in your activities of daily living in these areas? Okay. Then your physical exam is your objective assessments, right? Exam, your assessment of any changes since the last visit, segment, L5S1 is moving much more freely. Those would be the types of things that you would document, and then evaluate your treatment effectiveness. Give yourselves a pat on the back, right? So basically you say patient is responding to treatment very well. Now, you can also evaluate treatment effectiveness. Like, for example, one of the things that you should be evaluating in treatment effectiveness is if the patient isn't being compliant to the treatment plan. So you can state, like, let's say you put the patient on a plan of care, but they keep missing their visits, and then they don't reschedule, and then they just come in, whenever they want. You would then, on the evaluation of treatment effectiveness, state that the patient's treatment is not as effective due to their non-compliance. They are missing, they've missed the last 2 visits. We have reissued a new treatment plan to get the patient back on track. And we've stressed to them the importance of compliance to the treatment plan. So you can evaluate on the pro side or on the con side. If the patient is not responding to treatment as expected, then you want to evaluate that, and perhaps at some point you may need to refer the patient out for an MRI or something, but you can't do that unless you are evaluating on a per visit basis how effective the treatment has been. And then finally, documentation of the treatment given on the day of the visit, what you adjusted, what segments you adjusted, and if you did any other treatment, you can document that as well. So if you added some e-stim or some exercise instruction or some home care instruction, that would be documented as well. But again, the subsequent visit note doesn't have to be a long narrative. If you take care of business on the initial visit, you're going to have a much easier time documenting your subsequent visits. SE 1601 also reiterates the two types of conditions from Chapter 15, 30.5, that a patient's condition is medically necessary for treatment of an acute and a chronic subluxation. All right. Any questions on that? Let's see. Don't see anything in the Q&A. All right, I'm going to move on. So this document is actually a really valuable one that Medicare has published, and it in effect takes SE 1601 and puts it into a templated document for documentation compliance. So it actually gives you your template for documentation compliance, and it is called the Chiropractic Job Aid. And so I don't know if you've ever used it, but I highly recommend it. This is called the Medicare Documentation Job Aid for Chiropractic Doctors. And again, you can find it on Novitas. If you go to the specialty tab, click on chiropractor, you'll find a direct link to the Medicare Documentation Job Aid for Chiropractic Doctors. So essentially, it it tells you what needs to be in your documentation, and you can see that there are little check boxes, right? And so what you can do is you can use this to perform your own audits and your own risk analysis on your documentation, grade yourself, and look for any areas where you may be missing elements of documentation that could get you in trouble for not having a complete document or having insufficient documentation for your Medicare patients. So the documentation guidance includes, but is not limited to, number one, including the patient's name and date of service on all documentation. Now, if you do paper notes, that means that the patient's name and date of service should be at the top of each page of the note. Okay. And if you have an EMR, it usually automatically does that. It automatically has the patient's name and date of service on all pages of the document. Okay. The next thing is making sure that you have documented subluxation by demonstration date of x-ray, okay? It tells you that if you have used x-ray, you need to include documentation of your review of the x-ray. So not just that, note that x-ray was taken, but you need to do a radiology report or send the x-ray out to be read and then get a radiology report. Make sure that if you're using x-ray, that the x-ray has been taken within 12 months before or 3 months following the beginning of treatment. Again, it does state that Medicare can accept an older x-ray if the patient's health record indicates that the condition has existed longer than 12 months and reasonable to conclude that the condition is permanent. Or if you are proving subluxation by part exam, all right, it's telling you that Your documentation has to show at least two elements of pain, asymmetry, misalignment, tissue changes, including one that falls under asymmetry or range of motion. Include dated documentation of an initial exam. Include primary diagnosis of subluxation, including level of subluxation, and include the documentation of the presence or absence of subluxation for every visit. Include any documentation supporting medical necessity. Here is the template for your initial exam. All right, and I'm not going to go through all of these because we discussed them at length, but it gives you the recommended, and if it's not listed as recommended, it means mandatory. Okay. Now with that, here's my feeling. If it says recommended, do it. Better do it than not do it. Okay. And so make sure that you follow these bullet points and check them off. See if you are how you're doing on these templates. The treatment plan, there's a template for your treatment plan, and then there is a template bullet point for your subsequent visits. General guidelines for good documentation. Make sure that the medical records submitted show that the service is a corrective treatment rather than maintenance, okay? And again, using language like we are treating the patient today, visit 8 of 10 of a treatment plan, or visit 8 of a treatment plan of 12 visits to correct subluxation at these levels, okay? It doesn't have to be it doesn't have to be a PhD dissertation. It just needs to state that you are performing corrective treatment rather than maintenance. Okay. And what segments are you correcting? Okay. For Medicare purposes, make sure that the claim has an AT modifier on these spinal manipulation codes. And if you believe it's maintenance, do not put the AT modifier on if you believe that it is maintenance therapy. Okay. Submit records for all dates of service on your claim. Make sure documentation is legible and complete. Again, this is also a template for if you're audited, what do you need to include in your medical records when Medicare requests records? All of these elements must be submitted as part of your audit guidelines. Okay, and towards the end of next week, we're going to talk more about audits and what you need to submit. But all of these elements you should already be contained in your documentation, so that if an audit request comes or a request for records comes, you can simply print your notes, print all your documentation, and send it to Medicare, and put your head down on the pillow that night and not worry whether you have everything that you need or everything that Medicare needs to adjudicate your claim correctly. So let's talk a little bit about the challenges that you may have with those Medicare patients. The acute treatment patients are kind of cut and dried. They've hurt themselves, they've injured themselves. They have a sudden onset of a condition that requires a fairly short course of treatment. But then you've got this probably large population of Medicare patients who have chronic subluxations. And to prove that, you need to document that the patient has a functional deficit that can be improved with a trial of chiropractic treatment. And in order to do that, you need to create some benchmarks of what those functional deficits are. And one of the best ways to create those benchmarks is through outcome assessment tools. Now, most of us are aware of these tools. We just don't use them enough and in the right way. So I'm going to strongly encourage you, if you do have a population of Medicare patients in which you are working with them on treating chronic subluxations that are affecting their activities of daily living, that and you're not using outcome assessment tools, that you start doing that immediately. Some of the common ones are the Oswestry Disability Index for low back pain, the Neck Disability Index for neck pain. There are other ones like WOMAC for hips. There are shoulder assessments. There's a lot of them out there that are well recognized within the medical industry and within the payer industry to use as benchmarks for functional decline and functional improvement. There is a great website out there called orthoscores.com, and it contains a comprehensive list of online disability and outcome measurement tools for all different kinds of body areas. I want to share some of that with you today. And I'll show you the example of that website, but it's a great one. Now, if you have a patient who has a chronic condition, one of the challenges is going back and forth between active care and maintenance care. So anytime a patient comes back with an exacerbation or a reoccurrence of a chronic condition, you would want to have them fill out an OATS form and be consistent with to the condition. So if it's primarily a low back condition, you would have them fill out an Oswestry. So you would have them fill out the OATS form and then compare it to the last OATS and ask yourself the question, is there enough evidence between one of the last OATS and this one that the continued therapy could be expected to result in some functional improvement? If yes, then you're going to set aside the ABN, and we're going to talk about the ABN form next week. So once the patient goes from active treatment to maintenance care, they fill out an ABN form, okay? And you stop billing with the AT modifier. Maybe they decide to go cash, maybe not. But you set aside the ABN and you start billing again with the AT modifier. You place the patient on a new treatment plan. That treatment plan can be 3 visits, right? And then you move them back into maintenance. But if you don't feel that the OATS proves enough deficit and your objective findings doesn't prove enough to prove functional deficit that you can restore them back to a normal level of function, right? Then at that point, you have to let the patient know that they're going to be staying on maintenance, that yes, we'll help you. I know that you're in a bit of pain, but you don't have enough functional deficit for me to take you off maintenance care. So let's go ahead and get you adjusted today. And then, and then have you come back if you have significant deterioration of your activities of daily living in these areas. So you can help the patient remember what are the areas of activities of daily living that they initially came in with, and have them keep that in mind as they are going through their day-to-day living, okay? You do not have to re-x-ray if the following is true. So in certain cases, the older x-ray can be accepted, provided that the beneficiary's health record indicates the condition has existed longer than 12 months, and there's reasonable basis for concluding that the condition is permanent. And then write up another, we call it a micro treatment plan. So if the patient has a chronic condition, write up a new micro treatment plan, even if it's for 4-6 visits. Write it up the way Medicare says: frequency and duration, treatment goals, all right, to improve functional, to improve the patient's activities of daily living in these areas, and to get the patient back to a score of 12% on their OATS versus a score of 40% where they are now, right? Once the condition has resolved, the chronic condition, or is stable, and further treatment is not going to result in any more improvement of function, release them back to maintenance, have them sign a new ABN form, okay? So what are the recommended times to have the patient fill out an OATS form? The recommended times are at the first visit, first time you ever see a patient, as part of their intake, And based on their chief complaint, have them fill out their oaths. Okay, that sets the baseline. Have them redo the oaths at your re-exam intervals, and that at the final exam prior to releasing the patient to maintenance. That sets the maintenance baseline, right? Anytime the patient returns with a new condition, a new oaths form, and if the patient returns with a flare-up, you have them fill out an oaths. Now, I know this is a pain, and it may be a pain for the patient, but if you want to keep yourself on the safe side of an audit, this is what you need to do. And this is what you need to have your patients do in order to treat those chronic conditions as active treatment and not maintenance. All right, so this is the OrthoScores website. And I kind of love it because what it does is if you look at first, it gives you the region: knee, foot, ankle, wrist, hand, lumbar spine, cervical spine, hip, and it goes on. This is just the top part of the homepage. What you can do is, let's say you're going to use the oswestry. You can click on the patient completed form where it says oswestry low back pain score. It's actually a link, and that link will take you to the test. And you can have maybe a laptop or an iPad, and you can have this website up. What the patient would do is, once you go to the test, this is the oswestry, you can type in the patient's, you can type in your clinic name at the top. You can type on the top left-hand side. You can type in the patient's name on the top right-hand side and the date of completion, and then have the patient fill this out on the computer. The cool thing about this, and you can't see this, this is just a screenshot, but the cool thing about this is as the patient is filling it out, it's automatically scoring it at the bottom of the document. Once they have completed it, then you can have the patient say, okay, I'm done. Have your staff, they can print it as a PDF, and then it can be uploaded to your EMR, to the documents tab, and it creates a very, very nice professional looking document that you can then submit in the event of an audit. Okay. All right. Do we have any questions in this particular area? We have about 15 minutes left. I can move on to the next section, which I was going to wait until next week. But, one of the things about doing these classes online is we don't have as much stop and start and as much engagement. So I'm kind of finished with the first half of this 4-hour segment. Do we have anything in the Q&A? I don't see anything. Does anybody want to come off of mute and discuss any questions that you might have?
Lisa, someone asked if this will be available, the recording after. Is this something that you typically send to participants afterwards?
Well, we have this recording and it's on your side, right?
Yes.
I have no problem. I actually would like a copy of the recording myself.
Yes.
And happy to send it out. Now, I think a lot of that depends on you guys and whether you want to place this recording on the TCA website as give it, like, I don't know how your website works. If you want to give them a code for them to access the recording on the TCA website, and then have it for sale to members who maybe didn't take the class. I don't know. That's kind of up to you guys.
Okay.
And
Well,
whether you want to give everybody access to the recording. But yeah, for sure. I think
okay.
I think it's great to get access.
Absolutely.
Yeah.
I just wanted to make sure that was something we could do. So we'll definitely send it out to everybody that participated, and then we'll internally, our team will decide how we'll offer that to everybody else.
Yeah. Yeah. I see a couple of things coming up on the Q&A. If the patient has an Advantage plan, would you suggest we still make a copy? Yes. I would say that if the patient has an Advantage plan, you make a copy of all the cards, the red, white, and blue card, any Medicare Advantage cards, front and back. Okay. Now, with that said, if the patient has an Advantage plan, the red, white, and blue card is not entered into the billing system because you do not bill the red, white, and blue plan. You're going to bill the Advantage plan. So that card is just essentially put into their document section of their EMR or into their file folder if you're still on paper files. And it's just placed in there as a document. It's not used for billing, but it does need to be used to prove that the patient has Medicare and what their effective date of Medicare is. So yes, for identity purposes, you definitely want to make a copy of their red, white, and blue Medicare card. Next question, and it's a doozy. What is the most important way to avoid an audit? Well, there's a couple of things that I can point to. I'm going to tell you right now that 100% of your claims nowadays are audited. Okay. But I think what you're getting at is what is the most important way to avoid maybe a post-payment audit? And one of the most important ways to avoid it is so audits are at different levels. Your claims are audited in your own software. So think about that when you are have a bunch of claims that are ready to be submitted. What's the first thing you do? You scrub them within the software, and the software picks up errors on those claims, right? Now it's not going to pick up errors in your documentation, but it will pick up errors on your claims. And that's important because one of the ways to avoid audits is to send out your claim clean and error-free. Because if the insurance company receives significant errors every time you submit claims and those claims are rejected, those count as error rates in your profile. So we're gonna without getting in, I don't want to shoot my wad, so to speak, for next week, but we're going to talk about some of the things that cause audits, right? And one of the primary things that cause audits and will kick you into likelihood for a post-payment audit are claims error rates. Medicare, their threshold is about 8%. Okay, so if you're sending Medicare claims that have errors on them more than 8% of the time, you could be kicked into a queue for either a pre or a post-payment audit. And what that means is that, let's say you're sending a Medicare claim to the wrong payer. That's an error. You're using the wrong subscriber ID and it's getting kicked back from the payer because the payer doesn't recognize the patient. You're not billing it with the correct modifiers and the claims are denied. So excessive rejections and denials on claims can kick audits and trigger audits. So when next week, when we talk about billing and billing things properly, pay attention because, and you may want to, if you don't have your CAs or your billing team in, next Saturday may be a good time to have your billing team sit in on at least especially the first couple of hours when we're going to be talking about proper coding and submission of claims, how to use the ABN forms. Those are going to be key ways for you to avoid an audit. Other ways to avoid an audit is making sure that you are essentially following those guidelines that we just talked about. So for example, do you have any patients that you've been treating 2 times a week for 6 months and you're still billing Medicare with an AT modifier, right? What does Medicare say that would trigger that they say is an acceptable parameter. They say that for an acute subluxation, treatment can be as long as 3 months. Well, now you've gone 3 months beyond that, right? Medicare is going to want to take a look at that. And then if they take a look at that, you're going to have to prove that those additional 3 months of treatment has been for a chronic condition. Did your documentation prove that you are, can you treat a patient twice a month for 6 months? Yes. But Medicare is going to infer then that you're dealing with a chronic condition. So have you met the documentation requirements for treating a chronic condition? Where are the OATS forms? Where's your treatment plan? Where are your treatment goals? So all of that are things to consider when it comes to audits. Okay. We'll talk a lot more about that next week. And I think that you'll probably find next week's a lot more illuminating than this week. But hopefully that gives you at least a few answers. But your claims are going through audits all the time at every different level. And insurance companies, including Medicare and your Medicare administrative contractor, build profiles on you, on your group, on your provider profiles, and they do this through a process called data mining. So they have profiles on how many times do you bill 98942. If you do a lot of 98942 billing, which is the 5 regions of the spine, and you bill 90% of your claims as a 98942, that could kick an audit because that's not according to industry standards. Industry standards basically state that 98942, they would expect to see billed maybe 15-20% of the time, right? And that is in their data mining algorithms. So once you cross over into an unacceptable algorithm, that could kick an audit. And we'll talk about this a lot in March when I come to Lubbock and we talk about AI and how the insurance companies are using AI to set up algorithms that trigger audits and what can you do to avoid that. So hopefully that answered at least part of your question, and we'll try to get to the rest of them next week. Do we have
there was one more question in the chat.
Okay. Let me see. Pull that up. Deborah says, relative to original Medicare, is there an average number of visits allowed per year with proper documentation? No, there is not. Medicare does not ever define an average number of visits allowed per year. You have to go back to what they state, and let me see if I can get back to that slide really quickly. Let me escape and come here. Mm. Yeah, here we go. Let's see. How many visits? So this is what Medicare says, all right? And this is the only guidance they give you. They state that acute subluxation may require as many as 3 months of treatment, but some require very little treatment. In the first several days, treatment may be quite frequent, but decreasing in frequency with time or as improvement is obtained. That's the acute condition. Chronic, they state that the condition may require a longer treatment time, but not with higher frequency. They do not give any visits limits. They do not give any guidance on that. I kind of wish they did. I kind of wish Medicare would just say 12 visits per year, just like Blue Cross Federal, 12 visits per year and you're done. Great. Now, okay, now we can tell the patient it's 12 visits and now we go on maintenance, but Medicare doesn't do that. Medicare makes you clinically judge whether a patient needs active treatment or maintenance treatment. It is your clinical judgment that does that within these parameters. And I wish I could give you a better answer, but that's about it. That's what they tell us. So, um, let's see if there's any others in the chat. Nope. I don't see anything else. Yeah. Let's see if there's any other Q&As. Nope, I don't see that. So I guess if there's nothing else, we will let you guys go. We are right at the end of our time. It's 12:28. So I think we've
Yes,
done pretty well.
absolutely.
In the beginning of
Lisa,
this.
thank you so much.